can you guys tell me about airway or airway management or any of that fun stuff?
Probably the most important thing
Why?
to do. Without an airway, you're not breathing. Without breathing, you're not perfusing. Without perfusing, you're pretty screwed.
Yeah, pretty much. That's one definitely. It's definitely one of the key components there. You know, anybody familiar with Fick principle? The Fick principle. You'll actually talk a little bit more during pathophysiology, but if you want to get the real chopped down version of the Fick principle, you know, air goes in and out, blood goes round and round. Any deviation of the two is a bad thing. Fick principle just breaks down making sure you have an open airway, make sure you have alveoli, make sure you have red blood cells to carry it, make sure you have a contained circulatory system, and you have certain perfusion pressures. Okay, that's more the expanded version of Fick. You know, simple as air goes in and out, blood goes around and around. So, okay, I think we're going to talk about airway maintenance, and we're going to talk about anatomy and physiology review. We're going to talk about causes of respiratory distress, respiratory function, management, ventilatory management, out-of-hospital utilization, methods, so forth, and risks and aromatics. So, obviously, our primary objective is to make sure we have ensure optimal ventilation, deliver oxygen to the blood, and the big thing we want to do is we want to get CO2 out of the body. Why do we want to get CO2 out of the body? Want to take a guess?
It's the waste product.
Changes your pH.
Yes. And what does it do to your pH?
Increases it. Or
Increases
lowers your pH.
Increases your pH and makes you what?
Acidotic.
Acidotic. That's one of the big things. Yeah. Yes. You're right. It's a byproduct of cellular respiration, but we need to get it out. We keep it in. You know, like I said, you get acidotic, and you'll have a lot of other problems because what does acid do? It eats away things. What's the good thing that's going to happen in your system? You know, it's going to eat away cells. Cells are going to break down. Things are going to fall apart. So, okay, what is the difference? What is the definition of airway management? Okay. Anybody else? I mean, it's kind of an open. I always look at it as it's right tool, right job. You know.
Controlling someone's airway.
Yeah, I mean, sometimes yeah, it just depends. You might need to put an ET tube down there. You might have to put a nasal ET tube down, or just a BVM or a King. It just depends what they need. You know, you just got to look at the right tool, right job. The problem is we get paramedics get overzealous. And again, this is kind of falling back to more my little generation. Another thing we had was ET tubes, so we didn't have all the little toys that we do now. You know, so our thing is, well, we want to get a tube. We want to get a tube. But now it's kind of like, well, if you don't need it, why are we trying to break something or make it more complicated than it is? Right. So just like I said, think of this more as right tool, right job. If you're getting the effect that you want, is that a bad thing? No, don't ruin it. So, how does it differ from spontaneous manual or assisted ventilations?
Spontaneous is going to be your breathing on your own.
Right.
You may just need
Manual.
a little bit of oxygen just to help.
Yeah.
Manual could be
You're breathing for them.
or assisted BVMs and non-rebreathers.
Yeah, just give it a little extra push sometimes. That's all you need.
So is there a big difference between manual or assisted?
Manual is I'm doing it for you. Assisted, I'm working with you. I remember one time I had actually a guy years ago, actually a CHF guy, and his lungs would fill up, and we didn't have CPAP back then. But as soon as they started ventilating, he'd become conscious. He just, he's like, "You okay?" You just kind of nod or do this, but I just had to work with him the entire time, and that's that was kind of more unique of assisting ventilations. As soon as I stopped, he'd start checking out on me. So anyway, why is this important? Okay, the brain is a very finicky organ. It does not like to be disturbed. It likes to be in this little happy medium. The analogy I've used with other classes, it's like a little duck. It wants to sit in water and not be bothered. Do not put this on a test like a former student did, by the way. But yes, it's it wants.
Awesome.
You would be Huh? Oh no, I took points off. Actually, I said that was funny. Ha ha. Minus. Don't do it again. Yeah, you'd be surprised some things that have popped up on in tests, but Yes, it just does not want to be disturbed. It wants its oxygen, it wants its glucose, and it does not want to be bothered. It doesn't want too much pressure, it doesn't want too little pressure, but like I said, it is a very picky, very picky organ. Like I said, 4 to 6 minutes, we start looking at damage is occurring, right? We start getting into 8, you know, we're dying. So EMS providers can reduce additional injury with good airway ventilation techniques. Okay, and again, like I said, kind of think of it as, again, right tool, right job. What's the right technique for this? You know, we don't, like I said, are you looking at everybody and say, wait a minute, they got a laceration on their cheek, let's, you know, crike them? You know, do we need to, you know, put them down, you know, snow them out and RSI them? You know, you laugh now. You laugh now. So, big thing is that it's not just EMS providers that neglect BLS airways. Paramedics neglect BLS airways. There's a reason why you're going to see on the skill sheets, and we'll talk a little about that later when we for Saturday. You always start with a BLS airway every time. We can get so hung up of like, hold on, I need to get my, you know, my laryngoscope out, I need to get my, you know, my tube out, I got to do this, that, and the other, and the patient's like turning blue like that because you're just, you know, doing this. So, but yeah, we get very basic. In fact, it's very common for new paramedics to get basic stuff because we make you focus, and we kind of found this out. We make you focus on so much ALS stuff. We had to kind of start backtracking you guys and say, hey, look, start from basic, work your way up, unless it's like, again, extreme situation where you have to be a little bit more aggressive. But so anyway, here's your upper airway. So if any of you are ever really curious, yes, you can stick a pen or pencil down all the way back. Okay, so these are the your turbinates here. How many of you guys are familiar with nasal intubations? No one? You guys know what an
I watched it on YouTube.
Yeah, they're pretty cool.
You're the expert.
I haven't done one in years. Oh man, I miss those. You guys know what? They're fun. I mean, I'll show you guys. It's a true finesse. I mean, it is a lot of finesse. But okay, you guys know, how an MPA goes in, right? You know, right down there. Big mistake people do, and I've seen, because when we go to teach like ACLS, and you'll get a lot of people that don't do this or in any way, shape, or form. They follow along this line. They see this outside line of the nose, and they keep shoving it up there, and like, well, why is it going in? No, go straight back. Same thing with it. Same thing with the nasal tube. You just go straight back, and hopefully it'll curve, and you can manipulate it from there. But anyway, like I said, over here is your turbinates. Again, it's nice and mucousy. You know, should be filtering, making cold air and warm air. You know, lungs don't like cold air. You know, or gunk for that matter. Oropharynx, hypopharynx, big thing, tongue. You're gonna, run into lots of, tongue issues. Some of you guys who've done the quiz, what's this here? Why is that important?
When you're innovating, it's a landmark for
Okay.
the Mac blade.
Okay, what's difference? What's special about a Mac blade?
Curve.
It's
It
curved.
It has a indirect for the epiglottis instead of direct with the...
Yeah. A lot of times we're gonna say we're gonna have this little thing. It's gonna. I think I'd make that. That's my poor imitation of a curved blade. But usually when we go with the straight blade, we're trying to get everything up out of the way to get a clear shot of the vocal cords, and you'll see here in a minute. That kind of gives a more of an indirect way of accomplishing the same thing. So I used to use a curved blade all the time, but people kind of get preferences. Now I just use like a 2 miller, 2 straight. I can do anything with the 2 straight. So, but the thing is, just get familiar with all of them because it's good to have. Certain people and certain anatomies are just gonna be a little bit off. You may have to jump between blades, so just don't kind of limit yourself. Now, when you go to the OR, which I've heard of this happening, you're gonna go in there and say, "What kind of blade would you like?" Yeah, I'd like a 2. I'd like a 3 Mac. Well, here's a 2 miller. So just be careful of that. So, but big things to point out here. Again, it's the epiglottis. We got the vallecula. We got the epiglottis, because that's going to be obstructing us, believe it or not, when we actually do innovate and do airway management. The tongue can obstruct, and this actually can be a problem too. The esophagus, what do you think?
Put the tube in the esophagus, you're gonna inflate the belly.
Well, that's one thing. What's what?
Aspiration,
Yeah.
or,
What's going on down here, further on down? Digestion. You know, you're gonna see some guy, cardiac arrest, lying down, open his mouth, full of vomit. Because like I said, everything relaxes, comes up, and now you got, you know, airway issue compromise there, because now we don't, you know, hopefully the vallecula is, you know, or the epiglottis has dropped down on it and giving it some protection, but you got to suction all that gunk out of there. Nothing else here. Vocal cords, cartilage. Okay, so again, like I said, upper airway, we want to warm, humidify, filter, and like I said, it's formed by the union of facial bones. Have a nice little hard palate, soft palate, and lined with cilia. You guys remember what cilia is?
The little hairs.
Yeah. They go in waves, always pushing out. You know what happens when you smoke?
Kill them.
Stops them. Well, yeah, eventually it kills them, but yeah, it stops them, and they can't. That's why these guys wake up in the morning, you know, coughing that stuff out because it wasn't moving out anyway. The other thing you just got to worry about, adenoids. This is lymphatic tissue. You don't have to really worry about adenoids too much. So,
I
but
smoke sometimes, so he's giving me a hard time.
huh?
I said I smoke sometimes.
I used
he's
to
giving me a
I
hard
used to
time.
smoke for years, so I understand.
I
But
do this stuff, and I'm like, dang, I gotta stop that.
oh, don't worry. We'll talk about what smoking does to you later on in the lecture.
Yeah,
And trust me, it'll start making you think twice.
yeah, definitely.
You know, especially on the cellular level and really, you know, all that COPD stuff. Good time. So, oral cavity and oropharynx. Obviously, teeth is going to be a big issue, especially when you're intubating, because you don't want to break teeth, because that's a lawsuit. Plain and simple, that is a lawsuit. But teeth, especially if they're very difficult to open their jaw, they just don't have the flexibility. Some people are just, you got that much. You know, you might have to work with very little. You know, some people are going to have a little bit more. But that's more like next lecture we start talking about, you know, airway classifications and Mal and Patty scales and stuff and such. But understand we got a tongue, it's attached to the hyoid bone. What's unique about the hyoid bone?
It doesn't articulate with the end of the bone.
Yeah, it's just a bunch of ligaments that kind of, you know, help just articulate with that, really. So the palate, again, separates the oral and the nasopharynx, and of course we got the anterior, posterior, the hard and the soft. Okay. Anybody know? Uvula, yeah. So, tonsils, like I said, tonsils just kind of where they're, I mean, not unless there's something like it's really super infected. The only time you actually might see an actual tonsil issue is when if there's an infection, and you'll just see a lot of like white stuff all over it, and that's actually a bunch of dead white cells. That's, you know, kicking out gunk. Other than that, unless there's like a cancerous issue, and then you've got that's a whole different airway obstruction to begin with. Epiglottis. Epiglottis is going to be a big landmark to keep an eye out for. I mean, obviously, if you're going, you want to know where you are, because, like I said, if you don't, epiglottis will obstruct your view to the cords, and if you've got that obstructed view, at least you're in the right place. You know, because, like I said, when you sit and look at the comparison of the two, of the trachea versus the esophagus, it's like, okay, one's a collapsible tube and one's not, doesn't. But you lift everything up. Guess what? That tube. So we got two, you know, entries. We got to be able to decipher one versus the other. So, and the vallecula, like I said, forms a nice little pocket at the base of the tongue, and we just took advantage of it. So here's tonsils. Here's uvula. Teeth, tongue. Anybody not familiar with this? Okay, just making sure. Sinus cavity. ECA class. So sinus cavities, part of the upper airway anatomy, but most time, understand the only thing you're going to hear about is sinus infections. As far as airway management, it's not really going to be an issue for us. It's just, like I said, it's just the actual infection of the sinuses is probably going to be just more of a general complaint you'll run into. Even if actually you have facial fractures too, you just won't, like I said, just know they're there, really. Larynx. Okay, attached to the hyoid bone, horseshoe from nature, thyroid cartilage. Okay, this is going to be very important. You need to be familiar with your thyroid cartilage, cricoid cartilage, and your thyroid cricoid membrane. You're going to need to be very, very familiar with those landmarks right now, forever, until the rest of your life, that you continue to do this job. Okay? Okay. What's this protecting?
Turkey.
Uh-huh. What's over here?
Jugular.
Thyroid cartilage? Thyroid. Okay. Problem is, I can tell you right now, it's thyroids love to bleed. That's why you got to make sure you know where you're cutting on these things. I mean, all this is going to bleed. It's a very vascular area, but you start, hitting that thyroid, you're going to have lots more blood going on, and like I said, you're doing damage to the thyroid, and that's when you could screw their metabolism up on that one. But again, the cartilage, like I said, it's obviously, anterior thyroid, shield-shaped. Definitely, obviously, more profound in men. I have seen it profound in certain women types, but I'll leave that alone. If you ever guys decide to go further down south, you might understand what I'm talking about. And right behind, obviously, it's right behind the glottic opening. Okay, thing you got to start understanding is the difference between an upper adult airway and a children's pediatric airway. You need to be very, very familiar the differences between the two. Okay, because I don't know if everybody makes that little joke. Kids aren't just middle or adults. It's they're very disproportionate. They're just disproportionate. So understand with an adult, the glottic opening is your narrowest point out of this whole system right here. And it's usually what they kind of separate that upper airway versus lower airway, is that glottic opening. Okay, but that narrow part there is the narrowest for an adult. Obviously, it contains our vocal cords. It can be dependent on muscle tone. Obviously, it's kind of that. Obviously, a lot of it kind of. I want to say it's mostly somatic muscle at that point. The arytenoid cartilage, again, posterior attachments of the vocal bands. We'll kind of take a look at the picture here. The cricoid ring. Okay, this is the first complete ring we have. Okay, if you notice a lot of the rings, you don't really have complete rings in the trachea. They're kind of like this, and this part down here, smooth muscle. That's what kind of makes we get our contraction from. Okay. And what we do with that cricoid ring, since we know it's a full ring, we push down on it because we want to occlude the esophagus at that point, especially when you're doing basic ventilation. That's one way to kind of, get around that, so you don't have to worry about anything going in the stomach. We'll just close off the esophagus and just keep doing what we're doing. So, cricoid thyroid membrane, like I said, this is where you're cutting, where you're sticking a needle in. And the thing is, you got to remember, you've got a couple things that are going against you. When somebody is struggling to breathe, this is not staying still. This is going to be moving. So you got to make sure you got your landmark and you hold on to it for dear life. And obviously, once you cut this, and you cut this here, you got lots of blood. So you don't want to lose that, and you don't want to keep that hole open too long without putting a tube in, or else you're going to get lots of blood in there, and then we've really defeated our purpose, right? The other thing you got to remember is when you cut that area, this likes to move, and that piece below it likes to move, so they can go in different directions really fast. So your hole may end up right here, and the actual, cricoid thyroid membrane is down here, and you lost your landmark to put that tube in. That's the big things with these cricoid thyroid membranes. Okay. Okay. Associated, obviously, a thyroid gland. What is it? Thyroid, like I said, is obviously for metabolism. That's where your T3, T4. Is it thyroxine? It secretes thyroxine for your metabolism. You're going to see a lot of people, elderly, they might actually be like on Synthroid just because, or actually people that are postpartum can actually, ruin their thyroid at that point. So, carotid arteries, you have internal and external. Same thing with your jugulars, internal and external. Big thing with this, I don't know if I still teach how to cannulate these. Some people don't, because we got the drill and all that business, but they're actually pretty easy. Stick a big, we used to do it all the time. So, but just remember, you've got lots of bleeding. We got lots of bleeding that can go on here really, really fast. So, and again here, here's vocal cords. See how they're nice and shiny and white right here? That's a non-smoker, by the way. Remember that. You'll see smoker here in a minute. So, hyoid bone. Now, if you kind of look at this, when you think about this, here's this jaw. We're coming down here with this blade, and we got to make an opening. So that's kind of what, that's part of the thing with innovations. Where a lot of people, this is a natural reaction that people do. This is what gets people in trouble. But we actually are trying to lift all this stuff in an even motion out of the way, so we can see a good line of sight. So just remember that. I mean, all airways are a little bit anterior. Some people are just more anterior than others. So you kind of have to lift more, make more of an effort to get under all that.
Jason, what was the significance of highway bone?
It's the only bone that doesn't articulate with another bone, but it just attaches. Several ligaments are attached. It just kind of creates a focal point at that. But
So, is there always a space between the vocal cords, or is
Here?
there a natural space between them?
like
Or
here,
when you're doing your intubations, you have to push them apart.
no, a lot of times they'll be like this. Sometimes you'll open them up just because that manipulation. You'll see them spread because they're relaxed. Unless they're spasming, then they'll stay shut. But a lot of times, if you notice, like the tube has a bit of a beveled edge to it.
Kind of wedge it through it.
Like that. So you just use that. You just turn it to the side and it slips in, it makes the opening for you, and you're done. It's not that difficult. I think with innovations, it's just awkward and intimidating at first. And then after that, it's not that difficult. Okay, here's your difference between a pediatric versus an adult. Like I said, you better learn this and be familiar with this till the end of time. A big thing is that a pediatric has a very, very large tongue. It has a very disproportionate tongue. It will get in the way. On top of that, it's going to have a very large floppy epiglottis. Do you see the problems now? We've got a big tongue that can cause obstruction. We're going to try, put a tube down. If we have to put a tube down there, we got a big floppy epiglottis we have to maneuver around on top of it as well. Okay, they have very delicate teeth and gums. They haven't gone through the wear and tear that we have. Okay, their larynx is more superior. All this is superior. So all this is this has been made to shift back. This is a little bit further up. See the problem we're having here. Okay, it is a funnel shape at that cricoid cartilage. Okay, what's the narrowest point in adults? Okay. Narrowest point is the cricoid ring. Okay. And at about 8 years old, it actually expands open. Keep in mind, I think they say, what about our trachea is probably about open, our diameter is about the size of a dime. Theirs is like that. Okay. I mean, it really is. It's like that. Little children, baby. So when you think about when they get sick and get all the inflammation and coughing and stuff, it gets narrower and narrower. A lot harder to move air through. So here's your big differences here. Here's your funnel. So again, that's what you always get worried about, the foreign bodies obstruction. Doesn't take much to get lodged down there and get stuck.
But then it kind of help then hold the tube a little bit better too, like ET tube, because it is smaller at the bottom.
I don't know about
That's what
that.
the book was saying, but apparently the book's wrong.
I don't know about that. I mean, I've never really came across something that said, that. One thing I could tell you about ET tubes, they love to migrate. Even, biggest thing there's a big change of, because they talk about cuff tubes. You guys have read on that portion yet? You guys not familiar with what I'm talking about? ET tubes, usually what happens in an adult, we got the tube, and then we have a little balloon that can inflate to stabilize in the trachea. Okay? Yeah. The thought was, with children, they didn't want to do that. They didn't put that cuff on there because they were afraid that inflation of the cuff would do damage to the cells, to the cellular structure there, and would cause scarring, which would basically end up being stenosis, this narrows point, and it wouldn't develop right. And that was the idea of why they didn't do that. Now they're kind of looking and saying, well, actually maybe not do that. It doesn't matter. And they're actually coming out with pediatric tubes with balloons on them. So the thing about whether they hold them or not, I mean, I can tell you from experience, tubes love to migrate. They love to migrate. Because, I mean, we're not in a hospital. We're not just sitting there. We're not lying in a bed. We're not going, moving one place to the OR. We're doing this. All this is going on, shuffling around, junk's all over the place. So just remember, those things want to move. Those things do not take much to move around, especially when I'll show you a little PDET tube. But I mean, it only goes in about that far. Okay? So a little head shift, we pulled it right out. It doesn't take much. But yeah, be very, very familiar with the differences between an adult and a child.
So for an adult trachea, what kind of diameter are you looking, or is it like
a dime? Like a dime. Maybe a little bit bigger. Yeah, it's not much.
That's not much.
Now, I'll pull some tubes here at break, and I'll show you the differences, but it's not much. Like I said, but the thing is with kids, like I said, it's not much either. And that's why you don't want to. One thing is, one, they don't like you intubating. We try to get away from intubating as much as possible now because, well, one, it's if they don't need it and you intubated them, you just bought them a night in the ICU and if not, observation. So, if it can be avoided, that'd be great. And the thing is, like I said, let's say if there is some kind of inflammation or respiratory condition and you're sticking a tube down there, yeah, I mean, sometimes you have to, but you got to remember that's all irritating. It wants, body wants to protect itself. It's going to want to constrict. It causes even more problems, right? So, again, here's another, picture of the upper airway, tongue, vocal cords, epiglottis. Nice, easy way. Okay, this right here is a smoker. You see how dark and gray that is? That's what happens when you smoke. And that's why you start getting that nice deeper voice because, it takes all the nice elasticity and out of your vocal cords and you start talking like this. And then you start hearing those crazy, I've been smoking 30 years, I feel great. Have you seen that yet? I've always, yeah. What are you talking about? I remember reading. There actually were commercials in the 50s. These guys saying endorsing how much good smoking was for you. It's like, no, smoking's great for you. It does all these things. Yeah, I feel fine. Kind of thing. So, it's amazing. But yeah, that's what smoking does to you. But yeah, it's kind of the same thing here. I think this is a dead person. Everything looks very pale inside. Not a smoker though. Okay, lower airway. Obviously, this is where we exchange O2, CO2 within the blood. And pretty much where anything we're going to call lower airway, we're going to call glottic opening down at that point. So anyway, obviously trachea bifurcates. That place where it bifurcates is called a carina. We have the left and right main stem. I think you guys jumped ahead on the quizzes. Why do we tend to have more right stem innovations?
Does the stem straighter?
Lower angle.
Yeah, it's more of a straighter angle. That left is a very hard left. So right main stem is a shorter, straighter. Big thing here, what's beta 2 receptors? How is that important to us? What drugs can an EMT give for respiratory? What kind of drug albuterol is? Beta 2 agonist. Okay, that's when we're dropping albuterol. That's what we're shooting for. We want to hit those receptors, or even hit like racemic epi, which is basically an isomer of epi, just a little bit more, cut out a lot of the bad stuff. We're trying to hit the
muscle relaxation.
We want to dilate. Hit those receptors, we dilate. On the flip side, it's the muscarinic receptors that contract it. So just to let you know. There's one thing you're going to realize with the body is always one versus the other, opposing and the counter proposal. Especially when we talk about like alpha and the 2 alpha receptors. So bronchi go down to secondary, tertiary bronchi, then into the bronchioles. Okay, bronchioles, understand, are smooth muscle. Okay? Okay, smooth muscle at that point. You know what muscle likes to do? Yeah, that's very smooth muscle. You guys remember the term bronchiolitis? yeah, inflammation of the smooth muscles down there. So, branch at the alveolar ducts and at the end of the alveolar sacs. Okay. Obviously, remember alveoli, nice big balloon things. Inside the gas exchange. What is surfactant?
For the,
To help break the surface tension of the.
Yeah, but what? You know what? I'm trying to think how to phrase
They
this.
described it as a lubricant, or it keeps the,
That keeps the alveoli open.
elasticity of the.
It's like soap, to be honest.
it prevents alveolar
Well, the reason, yeah, it prevents them from sticking together. You know, because like I said, you know, that's one way to do it. But like I said, it decreases surface tension, so the molecules can exchange at that point. Kind of like I said, like soap. With when you use soap and water, you break down the surface tension so the water can come in, and the other junk can come out. That's all. That's all what surfactant does. Like I said, yes, it keeps it nice and lubricated. Because, like I said, all of that sacs are going out, open and close, and like I said, if you don't keep something there to keep them open, they'll just stick, which can actually happen anyway. And if they stick, they're called atelectasis. I think what happens. Atelectasis is probably more common with people that have posterior rib fractures. To be honest, okay. If you get a more posterior rib fracture, that's a lot of force to break those bones. Versus your floating ribs can be pretty easily broken. You break something down here, that's a lot of force and it hurts. And a lot of people won't breathe very deep because it hurts too much because it'll make those bones separate. So that's where they'll have atelectasis issue. You yawning prevents that. That's our natural, a lot of people I don't know if you guys we're in school, they're quit yawning or doing that. Your body's trying to say, I don't want things to collapse on each other. Actually, going into a thing called PEEP, but we'll talk about that.
So what does that have to do with being sleepy then and yawning more so than just yawning? Is it just because your alveoli are tending to?
I'm not sure what the sleep association is, but probably because if you're sleeping, you're going to be taking less breaths. Your breathing slows down, so we still got to keep. The thing about it's kind of a little bit touching what they call PEEP, pulmonary and expiratory pressure, and that's a nice way of saying we have a little bit of air pressure that kind of keeps things opening, and then when you yawn, we stretch everything out to keep it open, and then we have that little extra pressure that makes it stay open. If we have atelectasis, we actually have to lose a little bit of PEEP somewhere in that area because we need to get that air out. And that's in a collapse and sticks. Guy used to know in Colorado, smoker. Actually had a real bad case of atelectasis right there. Actually had to take a piece of lung out. Then he went. Then it popped into a pneumo. So anyway, lungs we have three right lobes on your right and two lobes on your left. Kind of interesting coincidence because you have a tricuspid valve on your right side of your heart and you have a bicuspid valve on your left side. So, you guys ever heard of sinus invertus?
What was that?
Sinus invertus? Okay. Well, it actually becomes more applicable later, but, with lungs that we're not really too concerned about, but the sinus invertus basically means everything's flip-flop. So your liver's over here, your spleen's over here, everything's just redone the other way. So you have, two lobes of lung here, three lobes here, your heart's pointing that way, it's going to be pointing that way. That's, if it's just your heart, it's dextrocardia.
So what do you do, 12 leap?
Just backwards.
Smallest percentage of people actually have that.
Yeah, it's very rare. But so anyway, parenchymal tissue, basically it's a nice way of saying chunk tissue for all intents and purposes. Okay, the pleura is we have the visceral and the parietal. And the kind of emphasis here is understand we have about 20 cc's of fluid between the visceral and parietal. Okay? And the reason is that it actually creates a little bit of a lubricant, and it also creates an adhesion. So when your chest expands, when you take a deep breath, okay, it keeps it like this. So we're always kind of keeps it intact to that thoracic wall, okay. And instead of versus saying, oh, chest goes out here, and the lungs kind of, there you go, catch up. So it kind of keeps it attached to that. The bad side about it is this is pleural space is also referred to as a potential space, and that's what causes a tension pneumo, because we have a space to build up air. So, but yeah, just remember we have about 20 cc's of serous fluid in there. Like I said, it keeps the lungs attached to the thoracic wall, so when next you breathe, it expands, the lungs expand with it.
So is that the reason, like with rib fractures, I've heard that they don't like to tight bandage around anymore because your chest can't expand as much when you breathe?
I think that's what a lot of it is. They don't want to stop. Well, I don't think it has to do with that. They don't want you to stop breathing because that will cause atelectasis at that point. It's just, good rib fractures. It's just, it sucks. Deal with it. That's the sad part about rib, especially ones down here. So anyway, here's our lower anatomy. You got lymphoids. Okay, understand this part right here is just the actual circulation to keep the alveoli sacs alive. Okay, this is what keeps the alveolar sacs alive. This isn't the actual exchange of CO2 to O2 for the major circulatory system. Okay, it has to. You're actually going. Honestly, even like for example, like arteries, they have their own little arterioles that supply them, blood, so they can get oxygenated. Just a little tidbit there. So hopefully this won't confuse you, but yeah. Because like I said, pulmonary, here's your pulmonary venule, pulmonary artery, or what's the other one? Pulmonary arterial, and so forth, okay? But the reason it's backwards, it's because actually there's oxygen exchange, but just keep in mind this is what is to feed the actual tissue of the alveoli. Okay, lower anatomy, again, occlusions. And this is always fun. I actually took out the other mucus plug slide because of like the big, gross, and nasty, and I've never seen one. If I ever cough one up for you, though, I'll show you. I do cough those up. You know what it is? You want to take a guess what this is? The plugs are? Huh?
Snot?
Yeah, it's just dried up. That's all it is. Dried up mucus. Kick it out. So anyway, big thing obviously here with the bronchioles, like I said, it's smooth muscle. It's basically just smooth muscle. That's the big thing you got to worry about here. And obviously if it contracts, it's going to get smaller. If it gets swollen, it's going to get smaller. If it gets swollen, we can't move air in and out, and things just kind of sit there and consolidate. Creates plugs. That's a really big thing you got to worry about there. But just understand, like I said, smaller unit. It's not going to take much to kind of plug all that stuff up. Adult males, generally we have about, lung capacity of about 6 liters. Be familiar with this term here, tidal volume, or the VT, volume tidal, as it's got really what it is. And again, gas volume inhaled or exhaled during a single ventilatory cycle. So, the actual equation, actually this thing right here, just to let you know, is what this 5 cc's to 7 cc's per kilogram. That's what they usually want to refer to that ideal body weight, not your actual body weight. Okay? But generally, by the way, you know like 500 cc's, or the heart, the heart rate of 80, 120 over 80 blood pressure comes from. You guys familiar with that? It comes from the studies that they did years and years ago of a 5'5", 75 kilogram male, and they based it at, and I was like, well, here's the norm. Okay, well, not everybody's 5'5", 150 pounds, and and so forth. But that's where a lot of those baselines come from. So just understand, obviously changes in height, weight. We're gonna have a little bit of differences. Okay, the other one here is dead airspace, volume D. And that's just air that just doesn't exchange for anything. And about out of that 500, 150 cc's of that is, like I said, dead air. And it just sits there. It just sits in trachea, sits in the bronchi. There could be other. If you want to look at other areas that could cause dead space, like you talk about like shunting. And we'll talk a little bit more about shunting when we talk about like PEs and pathological dead space, like COPD from smoking. because you blow. You know how smoking works, by the way. How it kills you. One of the ways it kills you. You have like your alveoli, a bunch of
It
these
kills
little-
that elasticity of the alveoli, doesn't it?
Yeah, that's one of the reasons, and also because like all these little bulbs, they pop and they get larger. So, like for example, your lungs actually have about 40 square meters of surface area, because that way more oxygen comes in, we can absorb more oxygen in exchange, right? Well, the more you smoke, those things pop and burst, and we start losing surface area. And we got these little holes that we can't really do anything with, and that air just sits there, right?
Sounds good. We'll go throw my
Nasty,
cigarettes
eh?
away.
Huh?
We'll go throw my cigarettes away.
That's why you see them do that negative pressure. That they're trying to create their own peak pressure. You know, it's just there's nothing there to force the elasticity. They kick it out. They gotta- So anyway, the rest of the alveolar, the less of ventilation that reaches the alveolar area is we're looking at about 350 cc's, and that's actually what we have in exchange for our CO2, O2, and so forth. So be familiar with these terms. VT, VA, VD, and so forth. Okay, emitted volume, okay, VM, MIN. Okay, the amount of gas moved in respiratory, so basically that's tidal volume times respiratory rate. But so if we want to find alveolar minute volume, we just get tidal volume minus dead space times respiratory rate. Little word of advice, always be familiar with equations. Always be familiar with equations. Functional reserve capacity, after optimal inspiration, the air that can be forced from the lungs after a single exhalation. So there's actually a picture here. It'll show the big, the FRC that's going up and down. Inspiratory reserve volume, the amount of gas that can be inspired with the additional tidal volume. Basically, if they ever do a pulmonary function test, they'll take a deep breath. They'll take a deep breath. Okay, keep going, and you're like, there's nothing coming in. You feel like nothing's coming in. There actually is air coming in. That's that reserve. Same thing with an expiratory. They'll sort of say blow. And you're like, and like keep going. The computer's still reading air coming out. That's your expiratory coming out. And like so, they actually kind of gauge between your upper, larger and lower airways how much percentage-wise are you using. So yeah. Max inspiration, actually inspiration, the FRC, the volumes. Don't just know it's there, how this is. We're not going to get too in depth of, I mean, guys, if you guys take a physiology, did they ever try to make you calculate what this person's expiratory? Oh, really? Yeah. I remember when I took physiology, it's like, okay, we want you to, how much residual volume would be with a patient who can inhale this much, da-da-da-da-da. And so you have to be familiar how to play with all these equations.
Is there any pre-hospital use for knowing like minute volumes and all that, or is that more like critical care stuff?
A little bit of both. The big thing you got to remember here is, for example, like your BDMs, usually geared for about 800 cc's of air. So we push, we're actually only counting on 500 generally. You get, somebody, larger frame, larger body, you're kicking you might be kicking the whole thing in just because they have more lung capacity at that point. So that's where it gets kind of tricky, or you're sitting there, you're ventilating somebody, it's like, wait a minute, I should be getting more, and I'm not. What's my problem here? Or maybe I'm putting a lot in, and I'm not getting any out. Make sense?
Yeah.
So, let's take a break here. Everybody looks like they're going to fall asleep on me. Okay, now we're going to talk about air movement in and out of the lungs. Obviously, it's controlled by the respiratory centers in the medulla, and then we have the apneusic and pneumotaxic centers in the pons. If I remember correctly, I think it's the medulla. You have the ventral respiratory group and the dorsal respiratory group, and one pretty much controls rhythmic breathing. I think it's the dorsal that causes rhythmic breathing. Then like ventral is the actual one, like if you want to take a breath or you want to breathe faster, like when you're running, that's what it takes over. So just a little FYI. Just you don't need to get that in depth, but just understand there's actually like I said, two groups within the that are actually kind of work with each other there. But for the most part, just understand, like I said, respiratory centers in the medulla. We back up the pons and so forth. And it's actually when we start backing up in the pons is when we start seeing different respiratory patterns. Because like I said, it's not really geared to as a primary respiratory at that point. So anyway, basically we have to have a stimulus. The stimulus has to go, to the respiratory center of the brain, of the medulla. So pretty much we got to have something that says, hey, you need to take a deep breath. What do you think is going to make you say that?
Too much CO2.
Too much CO2. Too much CO2. Too much CO2 builds up, and I believe you start getting acidotic. I don't think CO2 crosses the blood-brain barrier, but hydrogen can. And we start feeling that brain starts feeling registering that acidosis. Then it says, okay, wait a minute, we need to take a breath. Okay? All intents and purposes, just understand it's CO2. We're going to say CO2 is a stimulant. We have chemoreceptors, all that business, but just a little FYIs for you. But yeah, we pretty much get the, chemoreceptors say, okay, wait, we got too much CO2, which I believe are your carotid bodies and your aortic arch. And it says, okay, there's too much of this around here. We're going to get acidotic. Breathe. Take a deep breath. Move faster. We breathe faster. That is one of 3 ways. Actually, that is number 2 of the 3 ways we can start kicking CO2 out. Okay, and we'll talk a little bit more about the different ways we deal with too much CO2. So anyway, the medulla says, okay, guess what? Time to take a deep breath in. So that little message goes down to the phrenic nerve. Anybody know where the phrenic nerve is?
Background. Like,
the nerve. Yes.
Oh.
Spine,
Yes, it is in your spine. Where?
I don't pull it to look it up.
Okay, real easy to remember. C3, C4, C5, okay? 3, 4, 5 keep the diaphragm alive. You have a sever in there, you're not going to breathe, okay? So your phrenic nerve, actually if you go down here, then it goes into your brachial plexus and all that business. But anyway, goes down to the phrenic nerve. It's just a nerve and it says, okay, a couple things are going to happen. You're going to, your diaphragm sits like this, right? Kind of like this half. So it says contract, contracts, okay? Expand, okay? So what's the problem? What did we just create there?
Suction.
Huh?
You tell me when it expands, creates a vacuum?
Yeah, creates a vacuum. So guess what, you think the thing that we kind of really didn't talk about, we'll talk about a little bit later, you're going to see a lot of, diffusion processes, okay? Air here wants to be equal with the air in there. Everything always wants to be equaled out. So we do this, okay? We just created a vacuum. That's how we get air in, okay? So just remember that diaphragm goes from here down. Your intercostal muscles go out. I think it's your external intercostal muscles that actually pull your ribs kind of up, flail up and out. So anyway, okay, we get increase in size. We have a decrease in intrapulmonary pressure. Again, there's your negative vacuum. We get all of a sudden air just wants to sit there and equalize, and then all of a sudden, okay, airflow into the airways, alveoli inflate because obviously we've got that rush in. If we expand it out, we've got air to the alveoli. Everybody cool with that? You guys gonna remember this?
Yes.
Okay, that's just inspiration. Okay, expiration. Okay, this is one of those things that, by the way, it says your stretch receptors. It says there's stretch receptors in the lungs and inhibits too much inspiration. Okay, there's a couple things. Some of these concepts, by the way, just to let you know, they have not been proven per se. They're in theory. The hearing bureau reflex is found in dogs. They haven't found it in humans. Just to let you know that. When I was taking physiology, my the instructor there was talking about her doing late night lab work, and they're kind of doing this kind of lab work, but they were playing with horses' lungs and stuff. But they said they pulled the horse, and they actually put a cardboard tube, and they took turns blowing into this dead horse's lungs. They said it kept going and going and going and going. And I mean, there was nothing there to stop it, or so it just kept going. So just understand it can keep just doing that. So it's a natural elasticity. So obviously when we stop breathing and we relax all those muscles, what's going to happen to all this? Goes back down, pressure says kick it out. Diaphragm goes from this, slings back up. And well, obviously when you're running hard, we use our abdominal muscles to help push out, right? So anyway, and in most normal cases, though, we have natural elasticity, gets air out. Lungs are going to recoil back into place. So if I have elasticity, my lungs will go back into place. What if I have problems putting air in? What term would I use for making sure my air goes in good? So you guys might know this or not. You ever heard the term compliance? Yes, that's what it is. You'll hear this a lot of people when they're ventilating. How good? So I have good compliance. It's that air compliance
resistance or non-resistance, I guess.
Yes, or that lack of resistance. Versus, like I said, compliance. That's a good thing, but you need the elasticity. You need both pieces. To kind of keep working here. So anyway, pulmonary spaces decrease in size. Intrapulmonary pressure rises. Air goes out. We're going to try and go back to the equilibrium again, right? So, you guys are going to be familiar with this? All right. And there's your differences there. Again, atmospheric pressure at sea level, by the way.
Why would you need stretch receptors? Because it seems like once the pressure equalizes, it would stop expanding and then go the other way, or the nerve would trigger the muscles to.
I think with the idea of the stretch receptors, you don't want to overstretch and do damage to the lung tissue. But like I said, that's something they found in dogs. I don't think they've really found that in humans. It just says, well, if it makes sense, it's in dogs, it's in humans. In fact, when you guys talk about pathophysiology, have you guys gone through physiology? You guys know the action potential? Mm-hmm. Okay, you know where they get that basis from, by the way? A squid neuron. So, just let you know. So anyway, atmospheric pressure, intrapulmonary pressure 760. We drop the pressure. Obviously, we got a high-low gradient. Once equalized, and backwards and forwards and forwards and backwards. Okay. How much oxygen is in? What percentage of oxygen is in here? 21%. You ever want to play a fun game? And if you guys ever go into critical care or want to move up north, let's say you go up to Colorado, where the atmospheric pressure is about 650. Now we got a lower percentage of oxygen. Okay. When how long? By the way, how long do red blood cells last?
About 10 days or something.
What?
Or no.
Okay. I don't know who's
Like-
right.
Like 3 months. Okay.
That's what I said, 120 days.
I thought you said 10 days. I was
That
like,
is, that's it.
It's like,
No.
right.
People, for example, people who train in high altitudes, what they do is that lower oxygen concentration, it causes your body to create more red blood cells. More red blood cells, more oxygen carrying capacity.
Like blood doping?
That's the natural way of doing it.
Right, but then
Yeah.
they do that, and then they store their blood, and then they shoot
Yeah,
back in before
yeah.
they go to competition.
Now, if you shoot your blood back in with more blood cells, then it's called blood doping. Yeah, but if you go up there, then it's just hey, I'm at a high altitude.
People go up there and train and then come back.
Yeah, a lot of people do that. Yeah, the Olympic training centers up
But
in
it's
Colorado.
illegal, though, because they'll build up their blood cells in the thin altitude, and then they'll save blood, and then when they come back to regular altitude, so they have even more red blood cells.
Yeah, as long as they
It's
don't.
illegal in Olympics.
Yeah, as long as they don't withdraw it and put it in later, they're fine.
But they do.
Yeah,
That way.
that's how they get around. But yeah, they do that. And if we'll talk a little bit about the oxygen curve, you're probably not going to be able to do much anyway. You can only do so much.
If you have more red blood cells in your body, would that make you swell? Make you get more?
I'll make you. Yes and no. Okay, like obviously with chronic chronic bronchitis, you have that constant inflammation, but they also get with a condition called polycythemia. And that's because, actually, you also get with emphysema too, smokers. And the idea, what the problem is that you, because of the lung tissue damage, you're not getting as much oxygenation into the blood or into the cells. So the body doesn't recognize there's tissue damage. It says, well, I can fix this. I'll just create more blood cells. And that's why they'll say, like, your hematocrit, for example, is like 55% red blood cells. They'll start getting bigger because it says, well, I just know I need more blood cells because the tissues are saying, hey, I need more oxygen. But the problem is actually in the lungs. Kind of with me on that? So anyway, like I said, understand chemoreceptors in the medulla is stimulated by PC. By the way, that's partial pressure arterial CO2. Just to let you know. Basically, that A means it's in the arteries. If you ever see, V, that means venous, but don't worry about it. So anyway, pH goes down. So what happens if the pH goes down? What happens?
More acidotic.
We're getting acidotic. Body like that? No, we got to get rid of that stuff. So PaCO2 is normal neural regulatory control of ventilations. Hypoxic drive, on the other hand, and actually I had when I took anatomy, I took anatomy and physiology were separate classes, kind of like versus here, they kind of combine them. But my the anatomy instructor said he doesn't really believe the hypoxic drive really exists. And the reason he said that is they had an experiment where this guy was just kind of sitting there just breathing, and they slowly started taking the oxygen out. And he went unconscious because of all the CO2, but they couldn't find anything. He didn't register it. He didn't know that was going on, for this other drive to kick in. He just went slowly down. So, but again, hypoxidroid chemoreceptors in the carotid body stimulated by low O2. So it says, hey, again, another backup in the system says, hey, breathe. So, and a lot of times, the theory they think is obviously with the COPDers is that you're so used to a high PCaO2, it just kind of like, well, you just kind of like overridden it. You've kind of just kind of destroyed that. So we just kind of have to rely on is there oxygen concentration.
So, do their respirations decrease if you put them on high concentration of oxygen?
I've never seen it.
Well, that's okay.
I have never seen it. I had one person years ago swore up and down. She said she saw it. I'm like, I have never seen it. I think it's. I think for an extended period of time, it probably would, because like I said, if you got to think about it this way: if somebody's PCaO2, our normal is what 35 to 45 torr, for example, and let's say you're normally function at 50. And like I said, you have problems breathing, we give you oxygen. We're obviously going to kick down that 50 number too. That's going to drop as well. So your body may have adapted and said, okay, maybe about 55 or 50, we've got too much CO2, we got to breathe too. So we kind of off-centered each other. Make sense? But more or less the thought is, well, there's too much CO2. Body may not even care or recognize it, but it will recognize, hey, there's not enough oxygen. And so, is that you kind of with me on this? Yeah.
It's kind of a theory they came up with because they couldn't explain, so they just take the opposite of what.
I think there are chemoreceptors. Okay, I guess obviously stimulated by low oxygen levels in the blood. I guess I don't want to confuse you guys too much, but kind of think of it this way: if let's say I'm a smoker. Okay, and my normal PCO2 is about 50. Okay, and let's say my normal PA2 on the low end is about 60. Okay, you have to have at least 60 to have perfusion. Okay, well, I'm building up CO2. I go up to about 50, maybe about 51, 52. My brain says, hey, breathe. Maybe I'm sick. So I'm actually having a little bit higher buildup. It may take a while before my O2 to kind of drop and say, okay, breathe. But I'm still building up here, because I'm used to being up here. So I kind of offset each other. So this lower limit is actually kind of what's saying, hey, you need to breathe, despite the fact that you're used to being up here anyway. Make sense? big thing is, I guess the big point is that, like I said, the O2 we want to get rid of the acidosis. The PCO2 we want to get rid of because we don't want acidosis. The O2 we need it for perfusion. Like I said, we have to have that at about 60. So you can build just because you can build up one. That other one says you're not going to go below this number. We need this much regardless.
That's a 64.
No, it's not 60. Is it?
The book's at 80 to 100 for it.
Yeah, milligrams per mercury.
Yeah.
Yeah, millimeters per mercury. Yeah. So I've read. Yeah, generally I've heard 60, 65, 80, depending on what you read. So other stimulants or depressants, body temperature. What do you think happens with a fever? What do you think happens to your respiratory system when you're with a fever?
Increase your body force more to fight the infection or whatever.
You're gonna breathe
Oh, we're trying to blow off the
faster.
heat.
Am I blowing off heat? What do I need to create heat?
Energy.
Energy, right?
Okay.
So who's doing?
More CO2.
Yeah, you got to have cells working, right? Cells working create CO2. You know that's how we're going to keep that temperature up, right? That's where that fever comes in. It's like we're blowing up because we're working hard. We get a little bit, our heart rate goes up because, like I said, Fick principle here. Air has to go in and out. Blood goes round and around. We got to get rid of that CO2. We need more oxygen in. Everybody's working hard because we want to get rid of this bug in us real quick. Are fevers a bad thing?
Unless they get really hot.
Fever just means that your body's just working extra hard to fix what.
Yeah,
what
it
the
just
problem
it
is.
just makes.
So why are people so concerned with dropping fevers? Everybody takes time to say like a temperature. What was
The
it?
big-
Comfort thing, isn't it? Or
They have found with animals. Let's put this.
Yes.
I'm not sure where a lot of things kind of come from. But like for example, they found out that our animals can actually go up to a temperature of 106 and be fine. But we get about 103. We're kind of concerned that heat might be burning brain cells. Or the other flip side is they worry about seizures, okay, or febrile seizures. Well, the thing with febrile seizures, it's either spike up or the spike fast drop down. It causes a seizure.
It's not that it's hot, it's
Just
that
a
it's
rapid increase.
high.
Really fast. So, and of course, some people say, well, let's cool them down really fast. Guess what? You run the same risk. So fevers are good things. Prolonged fevers are not a good thing. So like I said, obviously it's a lot of energy, burning a lot of infection, and you're not winning the game. But the idea of the thought behind a fever is you're trying to make the environment miserable for whatever's inside you and kill it off and make it leave or do something. So that's why you go hot, you go cold. You got hot, you go cold. It's like,
So aren't you defeating your purpose by taking a medication that's going to drop the temperature?
to a degree, yeah.
Because then you're kind of
But because it's,
taking away that.
I mean, obviously we don't want to run the risk of how high is high, I mean,
As long as your fever doesn't drop this high in this amount of time, okay.
yeah,
No,
that's,
sometimes it doesn't take it down.
yeah, that's, so. You guys want to do a research paper on fevers? I'd be curious to see what you find. So, anyway, hypothermia, what's going on there?
too cold.
So,
Okay, so
what's your metabolic rate doing?
you're not.
Yeah.
Anything, so you're-
Do you need to ventilate as much? Yeah. Drugs? What can increase?
Cocaine.
Cocaine. What can decrease?
Alcohol.
Yeah, alcohol.
Weed.
Weed.
You didn't talk to that.
Weed. So, yeah, and again, that's something that, like I said, alters your, brain chemistry there. Doesn't really help us or, do any good. Yeah, I decided to take a bunch of opiates today. Not really breathing at all. Bye-bye, Gigi Allen. So, pain. Obviously, it hurts. Yeah, sympathetic response. We get a catecholamine dump. Heart rate goes up, breathing goes up because we're ready to move from it. But then it can go on the flip side, decreases, trying to compensate. Emotions. Obviously, you kind of get the same thing, that catecholamine response. Acidosis. Like I said, we want to get that out, get that stuff out. Sleep. Again, where metabolic rate's starting to go down. So anyway, combined total pressure of all the atmospheric gases, we're looking at 760 torr at sea level. Just remember that's at sea level. And again, these are partial pressures, you know, in a mixture. Obviously, the big one here is we always worry about is oxygen, you know, the 21%. Big thing is if you look, though, when we start going down to the alveolar level, that oxygen is only about, you know, 13%. Obviously, we're taking it up. Carbon dioxide is obviously 40 because we're kicking it out at the alveolar level, and carbon dioxide atmospherically, not much going on at all.
Do we need to know all the values at atmospheric and
Oh, I'd be definitely
like nitrogen and all that, CO2?
I don't know. I couldn't give you. I probably would. I mean, obviously the O2 and the carbon dioxide would be the ones you'd have to worry about. I mean, I don't think you're going to get one of those. You know, hey, you're at sea level, or you take a big rise of sea. That's more of a, you know, critical care kind of thing. You know, especially with a helicopter, you have to worry about that. So, what's ventilation versus respiration?
Respiration is actual gas exchange with tissue.
Yeah.
In and out, respiration, infusion.
Right. So understand we have external respiration, or sometimes referred to as pulmonary respiration. That's again the diffusion of, you know, CO2, O2 within the, you know, alveolar beds, you know, to offload and onload. Versus internal, this is actually at the, you know, again the cellular level with the tissues. You know, we're actually doing the whole citric acid cycle and all that business. So how is O2 and CO2 transported? Okay, it's it's diffusion. We're always looking to go to high to low, right, to kind of even out. And actually, the next picture kind of goes through. So anyway, just remember, gases dissolve in water, passes through the alveolar membrane, goes to high or low, because we just want to be even. We don't care. We just want to be even, whatever it is we are. Okay. FiO2, by the way, Fi stands for fraction inspired. So when we talk about room air, fraction inspired is 21%. We intubate them, put them on 100% oxygen. What's our FiO2 going to be? Huh? Yeah, 1. When you start playing with vents and stuff like that, they'll do a lot of this. And a lot of times they'll favor between, like, you know, an FiO2 of 0.4 or 0.6. They kind of lean away from putting in 100% oxygen. You have kind of run the risk of retaining more free radicals, makes cancerous, all that kind of business. So they kind of want you back to where you should be, where you normally would be. So understand, O2 across dissolves high to low on the capillary membrane and binds to the hemoglobin on the red blood cell. Okay, then hemoglobin goes for a little ride, and again, like I said, hemoglobin takes about 97% of your oxygen. The rest of that oxygen is just kind of free floating in the blood. And okay, so we go to O2 saturation. I don't know if I should get into oxygen sat curve right now. Okay, O2 sat, you know, percentage saturated with oxygen, total carrying capacity, you know, greater than 90%. O2 content divided by carrying capacity. So.
I don't know that it matters, but how does the hemoglobin like drop off the oxygen in the cells?
It's the same thing. It's a high to low concentration, and it'll actually pick up the carbon dioxide and become a carboxyhemoglobin and come back up, kind of thing. There's actually a picture here. It comes down a little bit better, and I don't know. There's also might want to get a little bit familiar with what they call the oxygen dissociation curve. You guys ever remember this? Heard of this? Okay. Okay, this is kind of really rough sketch, okay? Pretty much when we talk about oxygen dissociation curves, we're looking about affinity of O2 binding onto the hemoglobin. You guys with me on this concept? That pretty much says how much O2 is actually going to bind onto this hemoglobin, okay? Generally we sit at our magic 60, and usually we sit about 90% O2, right? But the thing is, when we start going, you see, if you kind of see here, this top part here, from like 90 up, kind of turns into this nice plateau. Down here, it drops like a rock, okay? So when we start getting lower, we start going up, and all this business, we start seeing it go lower, drop, 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 drop. We're not surviving, right? So what they talk about when they talk about a curve, they'll usually say it usually shifts left or shifts right. Okay? High temperatures, acidosis makes it shift right. So to get that 90%, it's now harder for oxygen to bind on that hemoglobin. Problem is because we got, we're dealing more with acidosis in the issue, and we're trying to deal with that problem on top of it. Okay? That's why we start flooding them with more oxygen, because, it's shifted right. Now, when you hyperventilate, it shifts left. And now there's more affinity to the oxygen to binding. When you have more oxygen to binding, you actually can hyperpolarize your cells, and that's why you start getting carpal pedal spasms, because it's able to cycle out that potassium and so forth. You guys with me on all this? Yes, no? Okay. Just kind of understand the, like I said, when we go this, we're shifting right. When we have a lot of times we're going to deal with a shift right problem. Okay, shift left problem we're not too worried about. Shift left problem, chances are, like I said, they're hyperventilating. Worst case scenario, they pass out, it'll regulate itself. Shift right, we're looking at fever, we're looking at drugs, we're looking at acidosis, all the above. And like I said, the O2 isn't wanting to bind as well as the way it should on the hemoglobin because of all the acidosis just dealing between. So that's why we're flooding them with more oxygen. But like I said, this curve going down is the problem. Because like I said, we go about 80, next thing you know, PCO2 is like about 50 and all this other stuff. So just kind of keep that in mind when you're looking at pulse ox, because that's all pulse ox does. It actually looks at, problem with the good and bad about a pulse ox, all it tells you is what's bound to the hemoglobin. Or I'm sorry, it tells you that the hemoglobin is bound. It never says what it's bound to. We always kind of take for granted that it's bound to an oxygen molecule. Okay.
So it could be bound to a CO2 molecule.
Yeah.
Carbon monoxide.
Yeah. That's why.
That's why carbon monoxide poisoning it shows a high
Yeah.
SpO2.
Yeah. And the other thing is, what if they're anemic? Well, the blood cells, but what's their O2? What's their saturation going to look?
It's going to look low.
High.
Because
Because they have fewer hemoglobin for the oxygen to
Yeah.
bind to, so it's going to look.
Everything's bound up.
So then in
So
the opposite direction, if they have too much hemoglobin, it'll look low.
no, it's just like I said. All that thing is like I said is using a near red and an infrared ray. It says, okay, is there something bound to this? Yes. Is there something bound to this? No. There's something bound to this. Okay, let's make a percentage. That's all it's looking at.
So then, really, what's the point of it if it's not accurate of what's?
I've been wondering that for years.
So like the
Kill my world.
CO2 is a lot more useful than
Yes. Yeah. Yes, end tidal CO2 is good because, like I said, if I have CO2 coming out, I know we have cells working. Okay? If we're doing CPR and, like I said, your end tidal CO2 is about 10, and I'm huffing and puffing and we're pushing and pushing, yeah, we may have blood going round and around and air going, all this other stuff, but cells are not working. They have not jumped on board yet. When cells jump on board, you'll see a big spike in CO2 come out, then pulses will return. Usually they'll jump about 50-ish, then about a minute later you'll start actually feeling pulses. So that's what's good about end tidal CO2. It says, we know you're working. We can smell the exhaust. How about that? So anyway, like I said, problems with low hemoglobin. Like I said, if you're anemic or you're hemorrhaging, I mean, yeah, you can have a high saturation, but guess what? You don't have as many red blood cells to transport. Problem. So inadequate oxygen availability to the alveoli. Again, what's the problem? Why is there not oxygen going there? Do we have a fluid issue? I mean, do we have a diffusion issue? Do we have an occlusion issue? What is the problem there? Poor diffusion across the pulmonary beds, pneumonia, pulmonary edema. Like I said, obviously we have that surfactant there. Reduce the surface tension, right? What happens if we put fluid? Look how much more trouble it has to travel to make that diffusion process. So VQ mismatch. Okay. This is one thing that everybody gets really, really confused on. Okay, this is the difference between PE versus atelectasis. Okay. Okay, here are my lungs, right? Let me see if I can find our. I could really use a red marker. I probably am not going to have one. Okay, well, bear with me then. Okay, let's pretend this here is pulmonary, your pulmonary circulation, right? As long as these two are working, we're matched up, right? We're doing good. Okay, what happens with a PE?
Yeah, clot in the lung.
And it blocks off the part of the lung.
Where's the clot?
In the vein.
Where?
Pulmonary artery.
Pulmonary vein. Usually in the pulmonary vein, right? Okay. Pulmonary vein. Do we have a match? No, we don't. Okay. That's why they call it a mismatch. Okay. So let's say, okay, all this is working then. I get atelectasis right around here. Do we have a match? Okay. So where is the shunt coming from? Lung, right? That's the difference between the two. So when they do a VQ scan, the V actually stands, the Q actually stands for perfusion, ventilation to perfusion. You know, if everything's working good, we should be okay. But if we see, you know, the mismatch, where's it coming from?
Well, we can't, there's no way in the field to test that.
No. I mean, PEs are diagnosis by exclusion. You got PEs sneak up on you.
And it's shunting.
PE shunts because it occludes the vessel, so it shunts on the circulatory side. Atelectasis shunts causes shunt from the ventilatory side. Got to make sure you understand those two concepts. Okay. So when they, you know, if I sit there and say I have PE, where's the shunt coming from?
Cardiovascular.
Yeah, it's coming from the circulatory.
Circulatory.
So if I have atelectasis side, where's the shunt coming from?
Pulmonary.
Pulmonary.
So you're saying PE, having a PE, you're not perfusing properly because of compromising cardiovascular system, and that atelectasis is.
No, you're jumping ahead. Okay.
I'm confused.
Okay. If I have a PE, okay, here's a couple things that happen, because that's, again, generic drawing. Because remember that pulmonary vein is going to break down, and come to more and more channels, right? We have a little clot, it's going to hit one channel, right? So let's say in this whole big lung here, we got like these branches here. Here's my PE. It sits there, it blocks us. Here's my shunting, because everything's going around, right? But the shunt is on the circulatory side. Okay, a couple things are going to happen. Air's still coming in here where the lung is, because the lung's working fine. But from here forward, in this vessel, nothing's going on. There's nothing to onload, offload. So we've mismatched at that point. Here, we've got oxygen, you know, CO2, we got oxygen, we're mismatching because we're equaling out. Nothing's going on here. We just have air sitting in here doing nothing. Okay, so this PE here occluded the vessel. This can actually also cause a pulmonary infarct, by the way, and actually infarct the tissue of the lung. So now,
Okay, go ahead.
yeah, versus let's say I have, you know, the lung, you know, here's the lung tissue, right? And I got my vessels, you know, coming across here. Well, let's say part of this, you know, goes in atelectasis. Okay? Well, guess what? I got air coming in out here. I can give air to this, I can give air in and out to this vessel, but this vessel is not getting anything. So that's where the shunt is, because everything's now going around except to that vessel.
So then the CO2 is just going to keep circulating. The CO2,
Nothing.
hemoglobin in that.
Everything stays stagnant right there. Nothing's going on.
Are the signs and symptoms the same if it's a PE or a?
No, the signs and symptoms are not the same. PEs are usually rapid, very quick. Understand about 70% will be diagnosed in the morgue, if that tells you anything. In the morgue.
Oh.
No, not in the morning.
Well,
No.
it could be in the morning. I guess.
70% will be diagnosed. It will, you know, most PEs, good PEs will drop you and kill you. Oh, yeah.
But if someone a portion of the lung, why?
Huh?
You still have, it's only,
It's a big clot.
It's the, okay.
It's a big, big clot. Because it's a big enough clot that it includes your pulmonary circulation, drops your pressure. I mean, it's like hitting, like, you know, somewhere in the you know, almost probably where the pulmonary
You usually
vein.
have blood back up in the lungs then?
No, because the blood is backing up back to right-sided circulatory. It never reaches the lungs. So your pressure just, well, you're done.
So it affects the vessels supplying the lung tissue and not the vessels that are undergoing gas exchange.
No, it's when the gas exchange.
Okay.
It can affect those if there's a bifurcation off those vessels, which can happen. This is where it gets a little confusing, okay? Because like I said, remember how I tell you like some of these little arteries will branch off and, you know, feed the lung and all this other business? Well, that could be part of that main vessel going through. So that main vessel coming through, yes, it's doing all this gas exchange, but it's also feeding that part of the lung as well. We're doing all this business. Well, guess what? We occlude that artery. PE comes in. Hey, we're going to occlude this. Everything from here is, nothing's going on from here. And we're not feeding all this tissue dies. With me?
Mm-hmm.
Okay, you with me?
No, you're right.
Okay.
Never say that.
So versus like with atelectasis, the tissue is a problem. The lung tissue is on the ventilatory side, pulmonary side is a problem. But all the vasculature is working fine, saying, hey, where's the oxygen? We're here. But you're not showing up.
So is that where the term, when it comes in, that says it's perfused but not ventilated and ventilated but not perfused?
Mm-hmm. Yeah.
Okay.
Yeah. So, alrighty, carbon dioxide, CO2 content, obviously byproduct of cellular work. Hey, that's always a good thing. Problem is when we're going to talk, we're going to touch a little bit about this. This is remember we're talking about the oxygen dissociation curve, and like I said, we're dealing with acidosis. Well, a couple things are going on here. We're going to talk about the buffer system. Okay, your body is built to deal with buffer, too much acidosis. Ideally, we want to have 20 bicarbonate to that hydrogen, okay? We're anticipating, and body does not like to give up bicarbonate, by the way. We'll always try to recycle bicarbonate, but we're always kind of keeping an eye out for acidosis, all right? Because what happens is, when there's too much hydrogen, this is going to come together, okay? It is going to come together. We got a negative, we got a positive. Sound good, right? So then we create this. That's carbonic acid. Okay? Then what we can do from there, we can break this apart. What can we do with this?
Water?
Huh?
Oh, no. The CO2? Blow it off?
Blow it off. That's one way. That's how we start dealing with this. The third part of this is actually go down to the renal system, but that's a whole different discussion. But this thing right here, this little equation, it's actually a really nice long equation, and it slides back and forth all the time. Okay? If we stop the respiratory, what happens if we stop the respiratory? All this starts building up, right? We start getting more of this, more of this. It's actually going to go back to this way because it says, well, you know what? I need to find a different way out of here. It'll come back to this. It'll come back to the carbonic acid, and it can break down. And then we got to build up of hydrogen. That's how we get acidotic. Make sense? So, and I know a couple of guys were jumping ahead on the quizzes, and they were talking about what happens if you're not breathing, what kind of conditions could be expiring. This is how we can cause respiratory acidosis. If we don't allow CO2 to blow off, CO2 is going to go back down and say, find a water, come to carbonic acid and say, how do we find a way out? Well, the other way out with hydrogen is through the renal system. Problem is the renal system takes way too long, so that hydrogen builds up. And that's where you're getting acidotic.
So could you give them fluid then? You give them the water to bind to the extra CO2?
You can. It's not. The thing is, it's when you look in, how quickly one can move to the other. This binding here is the quickest. Boom, done. We got this. Next one is we're going to jump down to is carbonic acid. We're going to break this down to water. We can deal with water. Water's cool. We can run with this. We're going to throw this CO2 on the empty hemoglobin, take it on out. It leaves, it goes away. We're fine, right? The thing is, yes, we can give fluid to this. Saline is really good for this to kind of start dealing. In fact, you can give like a good 500 cc's to somebody having a good asthma attack. But the big thing you need to make sure that CO2 goes somewhere. We want it out of the body. We keep it in there. We're fighting. We're going a big circle. And it's like, yeah, we've given fluid. Now we got to wait from the urinate. How long is that going to take? It's like so that.
So give some fluids where you kick into the renal system.
Yeah, we're really this water is we're trying to get into this to this. We're really trying to buy time. Is what we're trying to do with that. I mean, it brings it down, but we need that. We need respiratory open. We need this open. That's going to do the greatest good. Ketoacidosis, diabetic. This is what we're dealing with here. Okay, that's a metabolic issue, though. That's metabolic acidosis, okay? Big difference. The actual body's metabolism is what caused the acidosis. If I stop you from breathing, you're going to go into respiratory acidosis. So here's the flip side. What if I make you start breathing really fast?
You're going to blow up too much CO2.
So are you going to be acidotic?
Basic.
Yeah, no, that's hyperventilating makes you respiratory alkalosis. Okay, we've got too much oxygen in the system, and like I said, that's why I said, too much oxygen. They say can actually make you hyperdepolarized, start getting carpal pedal spasms, all that business. And that's why they'll keep going. In fact, I remember one girl, I actually just watched her passed out on me, and stopped breathing. Okay, started ventilating. EMT student was there, giving me big green eyes. Yelled at him a few times, kept ventilating. Finally, she started breathing on her own again. So that's the nice thing about alkalosis. Alkalosis is harder. Respiratory alkalosis will reset itself 9 times out of 10. I mean, worst case scenario, you'll ventilate for them. Metabolic alkalosis is usually a problem we cause. Is usually something we've done, because we're dumping too much bicarb, and that's a problem. Okay, acidosis is a lot easier to manage on our side. Like I said, and that's one of the easiest ways to make sure we've got an airway open. We want hydrogen to start binding to the bicarb. We want to split. Water can go one direction, but we know CO2 can get out really fast. Everybody with me? No?
Sorry.
It's okay. It's going to get more confusing. Where are we? Okay. So anyway, respiration, obviously, like I said, we're going to high to low concentration here. We got to cross this little membrane, get back in the blood, and so. By the way, how many different types of cell do we have in here, in the lungs? We have two cells types. Okay. Our alveolar 1 cells are the ones that deal with all this perfusion stuff. Okay. We want high to low concentration. O2 goes in, CO2 goes out, equalizes, da-da-da-da-da. Type 2, their job is to secrete surfactant. That's why we don't want to smoke, because if we lose our surfactant, what do you think will happen?
Collapse. Alveolar collapse.
Yeah, we're not, if we don't have surfactant, we don't have that reduction in surface tension, right?
Can't break that barrier.
It's going to be harder. So.
Can they do like they do PDs and give them the synthetic surfactant?
I don't know if they do that. Usually they give them steroids, inhaled steroids, just to bring down the inflammation. Okay. Just again playing with Fick principle here. Up here's your lungs, okay? Follow me, people get really confused with this. Okay, we have 100% O2 here, and we have 40 here. What do you think is going to happen? Here's the blood. Here's the lung.
From lungs to tissue.
Yeah.
To lung.
We're going to go, 50 plus, 100 plus 40, and we're going to divide in half, theoretically, and ideally we should have 70, but it doesn't show 70 here. But that's really what we want to do, because we want to be equal on both sides, right? What about this CO2 coming up? 46 and 40. Yeah, we got to, some of that CO2 is going to leave. We're not going to leave, obviously we don't ever really get all of it out. So, obviously we got less CO2. We've got more, actually this probably should be more like a 70 issue, than 100 per se. It comes down the heart says boom, boom, boom. We're kicking this back to the rest of the body. Now, this comes down to the actual tissue. Here's the little tissue. They're sitting there doing their work, minding away, doing whatever it is they're doing. Well, guess what? They need more oxygen. They have less than 40, and guess what's coming down the train? 100. What do you think is going to happen here?
60 is going to pop off.
We're going to take some of you guys down here. Guess what? Guess what we're building? We're going to kick back out. That's all we're doing here. Make sense? Okay. You all right, Ethan? How about we take a break? I think Ethan's going to explode on us or something. Okay. Diagnostic testing, like I said, talked about a pulse ox. Again, that's all it's registering is binding. What is something bound to the hemoglobin? It doesn't care what, as long as something bound. But generally, we kind of look at it as if everything's relatively okay. Yes, we're going to sit there and say we're going to call it oxygen unless we have something to make us think otherwise, like carbon monoxide or cold, anemia, other kind of issues. Peak expiratory flow testing and pulmonary function testing. Okay, understand pulmonary function testing is that we actually, like I said, they're making you do the whole breathe in, breathe out. They get a big old graph that looks like this oblong like circle thing, and like I said, it's registering how much upper airways are working together between inspiration and expiration. Peak flow, all it is just a little tube with a little butterfly thing in the middle. You blow, it goes into green and says okay, and that kind of gauges where your pulmonary pulmonary expiratory flow is to see how much of your lung is actually open. End-tidal CO2 monitoring is pretty much becoming the mainstay for a lot of things. Like I said, end-tidal CO2, again, understand end-tidal CO2 is different from PCAO2, partial pressure arterial CO2. One's in the blood, one's coming out, right? You guys with me on this? So when we talk about end-tidal CO2, we're thinking of it as the end. We're at the very end of the system, we're coming out. And again, like I said, we're looking at that as, okay, well, we're looking at byproducts of cellular respiration. We know things are working. The other one here is obviously blood gases, arterial and venous. Usually ones we look at the most are arterial. Sometimes they'll look at venous, and ones that we're talking about when we talk about arterial, obviously we're just talking about arterial gases like the PA CO2 or the PaO2 and so forth. Possible causes of hypoxemia. What's hypoxemia?
Low oxygen about hemoglobin.
Oxygen in the blood. So the problem is obviously lower partial pressure of atmospheric O2. What's a good example I talked about earlier?
Altitude.
Yeah, higher altitude was another one. Inadequate hemoglobin in the blood level. Give me an example. Anemia. Obviously, hemoglobin bound by another gas. Side. Okay. Increased pulmonary alveolar membrane distance.
If there's fluid or
Fluid.
something built up, it takes longer to get there.
Exactly. Reduced surface area for gas exchange.
Yeah, the adiquotative or
Reduced.
surface area. Because it's
Yeah, I guess
inflated, they increase the surface area.
Emphysema would be more the better example, but you are right. It is a decrease. There is a decreased surface area. So, and decreased mechanical effort. Trauma. What's that one there? Basically, compromises. We're looking at the tongue. Tongue's a big one. You lay on your back, tongue falls down, and so forth. Foreign body obstruction, big one with kids. It's angioedema, by the way.
Angio's the blood vessels, swelling in the blood vessels.
What's edema?
Inflammation.
Or fluid.
Itis is an inflammation. Fluid. So leaking blood vessels. When allergic reactions, burns sometimes can do that for you. And like I said, compromises all the capillary beds, fluids leaking out. And that's why you get that swelling in there. Histamine, by the way, breaks up all your gap junctions in your cells. Okay, when you talk about massive histamine release, allergic reaction breaks up those, because we want fluid to go in and out to get debris out and white blood cells to go in. Well, problem is with allergic reaction, we just dump too much histamine. So we've opened everything up. Guess what? We've made it, bigger than it is. So the same thing can happen with an airway burn. We compromise the tissue. We're breaking it apart. We're just breaking up everything. We actually got a lot of free-floating potassium, hydrogen, all kinds of goodies. That's actually at that point. Trauma, obviously it can be face, laryngo, tracheal, bronchial. Obviously, we break the system down. We're not going to get air now. Epiglottitis. What's epiglottitis?
It's the inflammation of the epiglottis.
Okay. All right, who can get that?
Children.
Anybody. Anybody can get epiglottitis. Generally, we see it more in kids, but anybody can get it.
Is it usually more severe in kids?
It's severe in everybody.
Smaller, doesn't matter.
Yeah. Years ago, I had to take a guy from point A to point B, and the doc I knew was just like, yeah, he's got epiglottitis. By the way, he goes down, crack him. It was no, don't even try. It's like, don't even try anything else. Just go straight, cut his throat. So, what about croup?
The narrowing in it of the trachea.
That's like the cough and the
Seal
swelling
bark.
in the lower airway.
Supraglottic, supraglottic inflammation.
Yeah.
So it's just above the glottis. Croup is not really the big one. A lot of croup you're going to run into. Bark, bark, bark. Take them to a different change of, environment. Cool air or moistened air or something like that. Usually you're fine. But worst case scenario, you give them a little bit of racemic epi. It's the epiglottitis. You're kind of sitting there like, just kind of watch, wait for something bad to happen. Hopefully it doesn't. So my tongue, the most common cause, snoring respirations, easy fix. We can lay them on their side. We can, if they're really, really unconscious, we can put an OPA in them, maybe an MPA. Real easy fix problem there. Foreign body, question is, where and what? If they're choking and if they're coughing, do we really want to be sticking anything down there to get it out? Because one thing we're going to show you later is a thing called McGill forceps, and that's a nice thing you can reach down and pull junk out. So, what are we going to do here? Symptoms here, obviously. Choking, gagging. What's stridor?
Upper airway,
High-pitched noise?
Yeah.
obstruction.
High pitch. It's the high pitched noise from that narrowing. Dyspnea. Yeah, difficulty breathing. Aphonia. Well, which one's which?
Can't talk.
Yeah. Yeah, aphonia and dysphonia is difficulty or can't talk. So the question is, how do we correct these things? I'm
What
sorry.
is aphonia?
Not being able to talk.
And then dysphonia is
Difficulty talking. Yeah, dysfunction. Think dysfunction A. The A is always think is absent. It's something is absent of whatever that next word is.
What's the difference between that and is it dysphagia? It's like difficulty speaking. What's the difference?
Phasia.
Isn't it?
Okay, dysphonia. Okay, dysphonia is the. Okay, dysphasia is the actual speaking. Dysphonia is the actual tone.
Can't make any kind of noise.
Yes. Did I confuse her? Oh, but I didn't confuse anybody, did I?
I got that one.
Okay. All right. So the question is, how do we correct it? It's kind of like, with what are we going to do with what? And like I said, that's where I tell before, it's going to be right tool, right job. Sometimes you might have to sit there and get the McGill forceps. Sometimes worst case scenario might be in the trachea. You might have to shove it down. Hopefully it goes into the right lung, and we can get everything else working around it. That's extreme cases.
How do they remove it then?
yeah.
Just
How would
surgically?
they remove,
Just go in there. And,
You ever had to do that?
It's one of those things of kind of like, hey, if it's their last ditch effort kind of things. But actually, one of the worst I ever heard of, I knew a guy who, some lady inhaled Cheese Whiz and got in her trachea. And you want to try getting that, and they're like just trying to fight to get that out.
My
'Cause
cousin's daughter was in third or fourth grade, and they were at school and doing some project with marshmallows, and then one of the kids decided to shove a bunch of marshmallows in his throat, and they started choking on him, and they just become sick. The kid died in class because they couldn't get it out. They couldn't,
Wow.
There was no way to. It was just stinky. They couldn't. Yeah, in the middle of class.
Yeah, something like that. That's one of those justifications of, yeah, you need you.
Do you
You're not
make
gonna
a
win.
marshmallow?
Yeah, you're not going to win on something like that. And you know, the big solid stuff, you know, that's kind of easy. You know, at least we know it's there, and we could probably, you know,
Toy car.
huh?
Like a toy car or something, you can pull that out.
Well, if they got a toy car in there, that would be
In that hole.
that would be impressive. You know, but like I said, the cheese whizzes, you know, look at those that gets real viscous. That's a nightmare. That is just a freaking nightmare. I mean, I don't know, just advance the tube and hope for the best. I don't know.
I mean, good marshmallow, but cheese whiz. That's
Well, she's probably doing like my son does with
good. You just squirt.
the, yeah.
So, laryngospasm, you know, spasmodic closure of the vocal cords. This is one, obviously one thing I'd be careful with burns, by the way. One thing we talk about with intubating with burns, we always set the good rule of thumb is always go one size down, because when we're always anticipating inflammation, same thing actually with an allergic reaction too, if you have to go that far. But you irritate the vocal cords. Like I said, the body's going to protect itself, and it's going to shut, and you're not going to get through there. So, and the other thing is, like I said, immediate aggressive, you know, intubation. Like I said, you annoy that tissue, it's going to protect itself, like any other part of the body. So, extubation. Actually, that's what interesting thing about extubation is when the patients do it themselves. That's actually kind of interesting to watch. You know, or pull it out their nose.
I've watched a lot of patients take out the NG tube, the feeding tube.
Yuck. I get to show you how to do those Saturday too. NGs and OGs are easy. It's just okay. Laryngeal edema, things you got to be careful for. Like I said, angioedema, anaphylaxis, burns, epiglottitis, croup, trauma. Like I said, anything that's going to cause swelling and obstruct that airway. I mean, like I said, this makes your workspace that much more smaller and more difficult. And like I said, sometimes you got to balance out of, do you really want to mess with this? You know, again, right tool, right job. Do we want to stick something down there? Do we want to just stick with something like a BBM? Are we okay with that? You know, are we getting adequate results? I mean, you really got to kind of weigh the pros and cons relatively fast sometimes, but think about what really needs to do. In fact, I'll talk a little bit, you know, a lot of ways I used to look at managing airway was I used to think about just kind of like a bell curve. And it's like, well, where's this person on the curve? You know, if they're sliding down the curve, they're buying plastic. They're sitting up on the curve, teeter-tottering, maybe a BVM assisting with them. They're kind of getting high on the other side, maybe in a non-rebreather if they're real low, cannula. I just always kind of look, where's this person fitting on the curve? And, or, you know, because if they're high here, they could slide down this way. Maybe if they're high on the other side, maybe they can slide down the other way and be okay.
Who can cause angioedema?
Actually, all the others, all these right here.
Oh, okay.
That's what's kind of ironic about that there. Aspirations significantly increases mortality. I think we kind of, talked about that. It destroys bronchial tissues depending on what it is. God, this was amazing. Years ago, I'm going down to central booking. You know, the temp nurse calls us because they, you know, this quote diabetic patient, yada yada. She's all, you know, sassing and doing this thing. Oh yeah, he's faking it, this, that, and the other. We take his blood sugar. It's like reading low. So of course my partner's talking. I'm kind of overhearing this conversation. We get an IV in, and I hit him with D50, and she's like, "Yeah, I've been putting oral glucose, but I think he's just full of crap, this, that, and the other." I give him the D50. Guess what he does? I watched him turn purple from here up. Yeah, it was one of those wow moments. So, yeah, it was just amazing. So yeah, but yeah, all that sugar in there is not really good for your lung tissue. You get that whole aspiration pneumonia, and some of that junk in there actually is very necrotic to your lung tissue as well. So, obviously, it decreases ability to ventilate, and sometimes they'll say it's frequently occult. Occult means we just don't know. We don't know really where it came from. You might hear, you know, the thing of, you know, one of those little things when you talk about actually with refusals, say, you know, hey, just to let you know, you might have some kind of, you know, occult injury or this and the other, and say, nice way of saying you have an injury that we may have not found yet. Sometimes they'll do like a CT of your belly and they'll say, oh, there's occult bleeding. We know there's bleeding, we don't know where. Other problems, asthma, emphysema, chronic bronchitis. Problem with asthma is, one, problem with asthma is that you trap a lot of air. Air goes in, but it doesn't go out. Like I said, it's inflamed, so when you pull and your diaphragm goes down, it pulls and stretches and pulls that open so air can come in, but everything's inflamed, so when it comes up, closes back up again. That's
You're sucking in air, but nothing's.
Mm-hmm. And like I said, you'll get actually, your lungs will get hyperinflated and all this other business, and it sucks. Versus like emphysema, this is where obviously we're destroying actual alveoli tissue, and they're becoming, like I said, bigger. And like I said, at that point, you're actually having to worry about less elasticity issues and less surface area on top of it. And like I said, you have to worry actually what they call, like I said earlier, PEEP. All that's starting to go away. Chronic bronchitis, on the other hand, again, it's just chronic inflammation. You get the chronic inflammation, you're going to see a lot of similarities with asthma, too. Ran into this interesting diagram years ago, and I always really liked it. Okay. These all overlap each other a little bit. So understand, if you have asthma, obviously the air trapping in there, you have a little bit of an emphysema issue. And obviously this one, you have a chronic bronchitis issue. Obviously, they all kind of overlap each other a little bit. Just kind of keep in mind with that. It's not kind of like a truly isolated event you're dealing with. Even if they are emphysemic, they still are dealing with the air trapping, hyperinflation of the lungs, and some of that tissue is going to be inflamed and swelling and so forth.
They're kind of like when you get with a patient, it's like, okay, you have COPD. It's like, yeah, the whole bit, COPD, CHF, emphysema.
Well, a lot of people a lot of times equivocate COPD with emphysema. Okay, COPD is this big umbrella that says, that has asthma, emphysema, and chronic bronchitis. Yeah, but just, why they do that. But yeah, if they sit there and say the whole bit, they might. It's very common to see somebody with emphysema that has asthma, kind of going back and forth. So, but like I said, they can be very intertwined. You can have a little bit of each. One could be the primary, but you could have a little bit of each. Pulmonary edema. We're talking about gas exchange, issues that cause gas exchange surface here. Pulmonary edema, usually we're looking at usually left-sided heart failure. The heart's normally used to pumping about 6 liters of blood. Well, you know what? The heart, for whatever reason, is only pumping 5.5. Well, that other 0.5 has got to go somewhere. Falling past leaves resistance. Hey, we got a lot of space right there. We'll just back up right in there and fill that there. So obviously, if we feel that, put that fluid in there. Obviously, like I said, that's going to cause obstruction for diffusion from A to B at that point. Toxic inhalation. The problem with that there is depending on what you inhaled. And if you decide for hydrochloric acid, for example, and you inhaled that, obviously it's going to break down your lung tissue, and that can cause pulmonary edema. So it just depends on the compromise of whatever happened there. Near drowning, same thing. Do we get fluid in there? What do you think about pneumonia?
Fluid in the lungs.
Yeah, it's all pustulant. It's mucus, pus, all that stuff, and it's rattling. It's like I said, it's got to be expelled. It kind of causes that plugging, and it causes that fluid obstruction on top of it. Pulmonary embolism. And we kind of talked about that. It's depending on, if you actually think about pulmonary embolism, it's just depending on what is the clot. So if a pulmonary, where's my mismatch going to be on a pulmonary embolism?
Circulatory.
Or which one, the V or the Q?
Q.
What's the Q stand for?
Perfusion.
Okay. Just think of it more to the V. Think of it more to the V or the Q side. Okay. So we get a good blood clot in there, and we stop the blood from going to one area. Again, we don't have any gas exchange. We just took it away at that point. So usually pulmonary embolisms usually result from clots in your leg, DVTs. Anybody want to know how amniotic fluid embolisms come? Huh?
That's what I was just about to ask you.
Okay, if you ever, when these happen, I think they're like almost like 99% times they die. When after birth, placenta separates, right? All those vessels are there, all that circulation's there. There's amniotic fluid. They get sucked back into circulation. It winds its way up to the lungs, and now you've got this nice viscous fluid that just blocked everything. Yeah, it usually anything I've ever read is just like, yes, you will drop dead, and you will drop dead fast. Other ways, trauma. Obviously, fractured ribs, we can't expand. Flailed chest. You guys remember what flailed chest is? Air goes in. Problem is that, basically I think of that segment going in, it's actually not really doing anything. The rest is all moving. That flail segment's just kind of sitting there, and you're just kind of watching the effects of everything around it move. Make sense? Mm-hmm. So, how do they, this is a terrible question. How are they saying to treat that now?
Flow test?
Yeah. Is that just saying just use your arm?
On the side, their side.
Is that what it is?
It's caught it. Or put a pillow there. Just anything to help stabilize it.
They used to tell us, sandbags, IV bags. I'm serious. Yeah. Yeah, I think it was that last. I think it was the last I heard to say just have their arm, because the problem is you just don't want it moving. Those bones grating, that crepitus there, it hurts like hell. Let's talk about tension. Let's talk about pneumos and hemos. Okay, how is that going to cause a ventilatory airway compromise there?
It's not going to let your lung.
Takes up the space of where the lung should be,
Yeah.
so you're not getting this much tidal volume.
Yeah, exactly. There. Sucking chest wound. Same thing. Here's one, diaphragmic hernia.
Your diaphragm's not working because
Well, that hernia is going to go up into your chest cavity.
It's going to take up the space.
Yeah, that hernia. Muscle splits, intestines go up. Actually, you can see a good congenital disorders happen with kids that come out that way.
Have you ever seen Scooter's X-ray of the hernia with the intestine and poo all up in the chest? Yeah, it's pretty gross.
Yeah, that is gross. What's a pleural effusion?
Just a guess, would it be like a hole in the pleural space type?
It is the pleural space. I'll say that. You are close. But it's not a hole.
Just abundant amount of fluid.
What?
Just a lot of fluid.
Yeah. Yeah. Usually I think with the pleural effusion, you can lay them back and they'll breathe and they'll be okay. They sit them up. And you'll start getting tired because that fluid accumulates, and when you start actually you have to do like an
equal it out when you lay in dirt.
yeah, it spreads
Or
out
goes
that
back
fluid.
further, I guess?
So, yeah, a lot of times it usually results in an infection, and once the infection resolves, the fluid goes away with
So
it.
what does thoracic vellows mean?
The chest cavity.
I don't know. I thought it was an actual symptom or something.
No.
I was reading these earlier. Oh, those are weird.
So spinal cord trauma, obviously, C3, C4, C5. You start doing that, we're going to have problems. That's what's going to do the contracting of the diaphragm. Anything that can do any of the nerves of the intercostal muscles to make the ribs contract. Pickwickian syndrome. What's the problem with Pickwickian syndrome? I've seen this, by the way.
That's the morbidly obese.
Fill up with CO2.
That they're
That they're too heavy.
they're so big.
They have too much weight on their arms.
Keep going.
Doesn't allow the chest to expand because of all that excessive
Yeah,
weight.
it's it's a circumferential pressure is what it is. Yeah. No, I saw that. Lady was like, gosh, she's probably like early 40s. And she was just sitting there sucking on the oxygen mask. She couldn't. She had to sit up. As soon as she started going down, watched her sats going down. I got more nervous. I said, drive faster.
Because you can't pick them up.
No, I couldn't. I couldn't. That's what I was just like, because I was like, okay, the only option is, wait for you to go unconscious and I can intubate you and deal with it like that because I can't
Then
do.
you're like,
It's going to be a
You're
struggle.
going to be fighting
The
the same
weight.
problem she's trying to
Yeah,
fight.
yeah. It's kind of a lose-lose situation. What do you guys know about polio?
It's a neuromuscular, it affects mostly the lower, from what I just, from a little bit that I read about it on here.
It attacks. It actually attacks. If I remember right, it's a virus that attacks in the spine, motor neurons in the spine. It actually jumps in those cells, and the problem is it uses those cells to replicate and kills the other motor neurons. It kills those cells in the process. Okay. Myasthenia gravis. Okay. The neuromuscular plate. Obviously, you have that little synapse there. Impulse comes in, hits the neuromuscular plate, muscles do their business. Well, on that receiving end, we have a bunch of acetylcholine receptors. Myasthenia gravis is this autoimmune that attacks those receptors. So there's nothing there to fire, and obviously the tissue atrophies and so forth. Muscular dystrophy. Yeah, it's actually the dystrophin. Actually, the term is actually dystrophin, which actually causes makes the muscles elastic. It destroys that. And Guillain-Barré syndrome.
Is that the one that, the paralysis that goes from the feet up the body?
It's over time.
And
You gotta start your feet
it's
and
just a
go up.
gradual
Mhm.
thing, it can happen over hours, and then if it gets up to that point to your chest and you're paralyzed from
Yeah, pretty much.
you die, you can die from it.
About 96% will resolve by itself. It's that 4%. Well, actually, 96% resolve in 3 or 4 days. That full paralysis.
Really?
Yeah, it's that 4% that doesn't. But yeah, it's usually after some kind of infection, and
Most of it resolves itself?
huh?
Most of them resolve
So like
itself?
Yeah.
anybody could have this, basically?
Yeah.
It's not.
You're talking about the whole world of autoimmune diseases. That's a whole different autoimmune. You guys understand the concept of how autoimmune diseases work?
Like the body attacks itself,
The
right?
body attacks
Yeah.
itself.
Every cell tissue has a little flag that says, "Hey, I belong here." Well, autoimmune disease, for some reason, we lose those flags. We lose those flags and say, "Well, you're done." Yeah, then you start throwing the whole antigens, the antibodies. Boom, you're done. But yeah, it's usually after an infection. It starts some kind of autoimmune response, and it attacks the demyelinization of your neurons. Unless you get paralyzed and all this other business. But yeah, it starts from toe up.
Isn't that what MS is? Too? Did it attack the
Myelination.
pollination of
No, you're right. No, you're right. That is. I'm sorry. I'm getting you guys. You're right. That is it.
I saw it on Untold Stories of the ER, and that's how I remember it. Because a girl had the symptoms, her foot, one of her feet,
Yeah.
she couldn't feel it, and then she would, and it was it almost seemed like it was kind of sporadic, and then it went to the other leg, and then she tried to get out of bed the next morning, and she couldn't feel anything from the knees down, and they took her in, and by the time they diagnosed her, it's up to her waist.
No
And
stress.
talk
No
about
stress.
They were panicking
No stress.
by the time they figured that out. And then she was fine, whatever they did, I don't remember the treatment.
A lot of times they just intubate them, snow them out, intubate them. They don't remember it.
Sit and wait then.
Yeah, wait it out. And then, like I said, a lot of times they just kind of take off. If you ever look on ICU, they don't usually have them on paralytics. They usually just have on some kind of maintenance agent to keep them just snowed out and like first set or something like that. So if there's any spontaneous movement, they're going to be able to see it.
says it damages parts of the nerves.
For which one?
It does the
Beret. I thought I thought it had to do something with myelin.
yeah, it says it syndrome most often attacks the nerves covering
Yeah.
the myelin sheath.
So. All right, here's more fun stuff. Obviously,
Brain injury.
Yeah, good head bleed. We get pressure. We start, shoving our, midbrain through a foramen magnum. You're
one little thing can go on the brain and you can get so many different results.
Yeah. So yeah, any kind of head trauma, like I said, we start getting. Like I said, brains are very, very finicky little creatures. Head trauma, CVAs, and like I said, any of your bleeds, can do it. We talked about drugs. Who's here is familiar with narcotics? Russ. Sedative hypnotics, Russ? You guys know what ethanol is? Yeah, alcohol.
Yeah.
That's a weak. What do you mean? We just call that Saturday night. So anyway, respiratory distress dyspnea equals possible life threat for the obvious reasons. So obviously management here is kind of simultaneous. The big thing here, obviously, they always talk about checking airway and circulation, but obviously if we're checking airway, we're kind of stuck with dealing with an airway problem. You're just there. And that's one thing you're going to kind of realize. You get a real bad airway problem. It's like, yeah, you got to make sure they have a pulse, but you can't get away from it. Airway deal has to be first before you can move forward and really start dealing with everything else. So, again, airway, breathing, circulation, disability. Listen to the patient talk and breathe. You can tell a lot from there. Noisy breathing obviously is obstructed, but not all obstructed breathing is noisy. Adventitious. Snoring, tight snoring. Adventitious is a very general term, by the way. It's just saying not right. So, big thing with breathing, obviously, if we know the airway's intact, at that point we're going to look at the breathing, and breathing is a nice way of saying, okay, let's listen, check their lungs and the thoracic bellows for Ethan. And symmetry of the chest, increase effort, skin color, listen, lung fields. Okay, always listen to all your patients' lung fields. In fact, you better be very careful, patients, especially if I'm coming around doing scenarios. I love to throw curveballs constantly. I will feel symmetry. I am not going to feel your mouth and nose. And if I have to stick, huh?
Put your cheek down by their face.
No. Most I'll do is this. I won't even, I just don't even like sticking my hands in anybody's, just, no. Unless I know you are truly out and dead, I am not sticking my hands in your mouth. Last thing, knowing my luck, I've always been afraid, I just kept thinking my luck, I'm going to do like some, because you can digitally intubate somebody. This would, you do that, you just go there, go up epiglottis, you do this. It's actually kind of fun. But after I was thinking about it, it's like, knowing my luck, what if I have that one reflex in?
Yeah.
They have another
We
airway
just really
obstruction.
let the dentist have it and you put the silver, so I kind of like.
That's awesome.
That's your best friend right there.
Yeah, we need some of those. That and the big thick zip ties that cops have. That also solves some spitting problems too. I like the way you think, Russ. Okay, what's tachypnea?
Fast breathing.
Okay, bradypnea. Okay, big things here, signs of distress. Okay, and especially if you see this in kids, it's really, really bad. Okay, but nasal flaring, very, very bad. Tracheal tugging, really, really bad. Retractions, why are we having retractions?
Because we're trying to use all of our accessories.
Yeah. We're using we're trying to give everything we can, stereomastoid, muscles, anything we can get going here. Tripoding. What's tripoding?
Hands down.
Years ago, I remember this guy, he's probably like 60 some odd years old, smoker, by the way, went to his house smelling of smoke, and he was having real bad, strong breathing. He was doing the whole stand-up thing. I remember my partner nasally intubated him, just like that. The guy did not fight at all. He was miserable. He was like sat in like at 76%, not doing too good. So yeah, it was pretty impressive to see somebody stand up and just take a nasal tube. So cyanosis, obviously. When would you not be too concerned with cyanosis? Yeah, if it's really, really cold out, because then we, at that point. So don't let respiratory failure distract you from circulation. Like I said, hopefully if you're checking your ABCs, you're checking them relatively quick and almost simultaneously. Usually what happens is you'll see with a lot of people that have been in the field for a while, they get in real bad habits of not really thinking about that. And then they're talking, and then all of a sudden they don't realize why the patient, kind of passed out. Well, because, they didn't even have like a palpable pulse, and when they did have one, it was about 20. Little things like that. Or something I learned the hard way one time, ladies screaming and yelling at me, I can't breathe, and of course she reeks like alcohol. So what do you think my mind's thinking at that point?
Okay.
Yeah. Yeah, come on out, let's walk to the truck and all this other business to get up. Huh?
Come down here.
And of course, my lips are turning blue. My EMT partner's like, you want to put on something? Hold on here, hold on. You want to put some oxygen on this person? Hold on here. And of course, I had to put the monitor on. Okay, brand new paramedic. As I put the monitor on, she's at a heart rate of like 290. No wonder why she can't breathe. She's got all this air in, but she can't get this oxygen, off in the rest of the system. Yeah, it was at 290. I'm like, yeah, it was a funny freaking. Oh, it even gets worse. It even gets worse. We get a. Remember the fire medic came by and he's like, "Hey, you need help?" Yeah, get in to help. You should have seen this. We're trying to get an IV, and this was back in the day when we had to call for orders. So I'm like on the radio. Yeah, I need to get an order for a desi. I'm like talking. Yeah, do whatever you need to do. Kind of thing. And well, the thing is, keep in mind, the last time I actually cardioverted somebody was in school. And again, these old junkie, they were like really, like, I'll show you like one of the old junkie monitors we were using a cardiovert versus like we didn't really use the new ones like we do here, the more up-to-date ones. Well, I didn't know after you hit sync, you get a little ting, 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 because it's going to hit right on the impulse, okay, when it discharges energy. Well, most, you think, oh yeah, I hit, shock, it goes, right? Well, this machine, you have to hold it down, and then it will shock on those markers. So you should have seen me and this fire medic. We're trying to figure out how to work this machine. We're pushing this button. What the hell's going on here? And then finally we kind of figure out what we're doing wrong. And then we're like worried about getting electrocuted ourselves. So we're just kind of like huddled up on the bench of this, van ambulance. And this lady's sitting there, crumped over. Boom! We wait. Oh, she's doing it again. Okay, we can do this again. We can do this right this time. We got it down. Boom! Okay, she's asystolic.
No.
She's staying asystolic. And we're just looking at each other like it sucks. So, of course, get to the hospital. The guy who happens to open the door is the guy who precepted me. And he's just looking at me like, hey, what's going on? I'm like, I quit. But yeah, after that, her pulse started coming right back and everything. It just took a little bit longer. But lessons.
She came back?
Yeah. Yeah, you can go asystolic and then it'll take your heart rate. That's the idea. Is you're trying to actually depolarize your heart, stop it, but it was just taking a little bit longer than normal, and we're just kind of like,
Please come back. Please come back. Please
waiting. Okay, this is not supposed to go in the. Yeah, it was a fun day. So yeah, that's where again, don't let circulation pass you by. Even if they are yelling and screaming at you, they can't breathe. There might be a legitimate reason, right?
Would you think if they're yelling and screaming, you're breathing?
It was at 10%.
Yeah, that 10% that got me, Yeah, but the thing is, if you think about it, it makes sense. The heart rate's going that fast, the oxygen isn't going, you're going to feel short of breath. So, disability, restless, anxiety, combativeness, hypoxia, until proven otherwise. Anytime you get any kind of restlessness, anxiety, understand the point they always try to make here is put the psych issues at the very bottom. Make sure we rule out all the big stuff, and then we rule out the metabolic stuff, and then we work our way down to the psychiatric issues. And even if they are psychiatric issues, deep psychiatric patients still get sick too. So, drowsiness, think hypercarbia, till proven otherwise. When the fighting stops, a patient isn't always getting better. Maybe easier to manage, but doesn't mean they're always getting better. By the way, on the flip side of this, if you do find somebody who is decides to sit there in their car, do the whole garage thing, and turn their car to kill themselves, word of advice: when you do give them oxygen, be ready. They may want to fight you because they're going to go in reverse order, be unconscious to semi-conscious to combative, and then finally come out of it. So understand they can go down that direction and come back up that direction.
And the thing that I learned with the carbon monoxide poisoning.
You sit in the garage too, or what?
Huh? Is what? Yeah, don't smoke in your garage with the car shut, with the door shut and the car on. I had a guy that I worked with that almost died from that, and he ended up with some brain damage because he didn't get enough oxygen.
Yeah.
You
Oh,
have
yeah.
to, like, oxygen, I mean, as much as you can, because, you know, the cells have all the
Depleted.
carbon monoxide, I mean, they have to get out.
Oh yeah, and like I said, it's going to take a lot longer for the carbon monoxide to get off those cells before that oxygen gets in those cells. So, in fact, was it that usually you see a very common EMT question, like how many times faster does CO2 bind to hemoglobin? 200 times. So.
Faster?
Mhm. You like that one, Ethan?
Yes, that'd be good.
Okay. Talk a little bit about respiratory. You guys familiar with Shane Stokes?
That's the pattern of breathing that gets
The crescendo.
faster and slower, and then it
Not-
repeats in a pattern.
Shallow, shallow, deep, 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 shallow, shallow, deep, deep, deep. Kuzmal. The big thing with Kuzmal is it's very just fast. That's all it really is.
And it deep, pretty deep too.
Yeah.
Just trying to-
Like I said, you're trying to blow off CO2 because we're worrying about that whole acidosis issue, you know, from breaking down all the ketones and all that business. Biots. Actually, you might run into, you know, depending on what you're eating, you might biots, ataxic, and I think there's one other one out there. But pretty much what's saying is when medulla has been injured and then we're kind of injuring into the pons, it's a completely erratic breathing pattern. There's no rhyme or reason to it. You know, whatever's firing is kind of firing, but there's no organization in the brain to keep a rhythm at all. So just remember that when you see biots rhythm, you know, you've got one bad head injury of some sort, you know, whether traumatic or you know, vascular, however you want to put it.
Is that the one where the two back up it was apluristic and the
Ataxic?
the one that inhibits inspiration, the one that inhibits expiration are like combating with each other?
They're not even combating with each other. Just kind of like, okay, this we somehow we managed to fire. Maybe this one manages to fire. Maybe it doesn't. Maybe a couple fires. There's no organization to it.
Some kind of head problem.
Yeah, it's either trauma, bleed. You know, something's going on. It's central neurogenic. Okay, you guys okay? Yeah. The thing is, talk about ICP, increased intracranial pressure here. The reason why they're blowing that hard is they're actually trying to blow off CO2. Your brain cells have a lot of glutamic acid. So when you blow a vessel in your head and you actually injure your brain, all that glutamic acid comes out and goes into the vasculature, okay, from your brain cells. Causes a couple things. Causes constriction of your vessels. There's where you get your high pressure, okay? But like I said, it's also acid, so we got to do something with this acidosis. We need to get rid of it.
It's fast heart rate, fast.
No.
Or fast.
Huh? Yeah, heart rate's going to decrease. It's got enough sense to say we push hard with this much pressure here, we're going to create more of a problem. So we're going to like I said, that's what that glutamic acid does to the vasculature, just does that to it. So that's why you get that neurogenic hyperventilation that you know, just trying to blow off all that acidosis. Agonal, you know, your last breaths. before you part this world. Then we come and ruin it. Other things to look at, neck is a trach midline. You'd realize tracheal deviation is a very, very late sign. Very, very late sign. When you're looking for issues of tension pneumos, for example, or hemopneumos, big things you want to look for is one is a trop, a very low pressure. Okay, do you know why? I think I'm kind of jumping a little bit. In a pneumo or hemo.
Because it's common cardiac output.
Yeah.
All the pressure.
All the intrathoracic pressure's coming down. Obviously, you're going to get the distended neck veins. You can't drop, blood.
Is that late time?
Huh?
JVD?
No,
That just kind of a sign.
kind of a medium, really. It can kind of be of a medium sign.
But trachea is just late time.
Trachea is late. Big thing. First things you're going to watch drop is your pressure. Pressure is going to drop really good. Obviously, there's going to be an injury. Obviously, they're going to be tachypnic. Obviously, you're going to hear the hypo and hyper, or the hyporesonance or hyporesonance, whatever the case may be. And like I said, it's just going to start. Think of it just more of a cascading effect. Obviously, this will go back up, and then one will shift to one side, and so forth. And like I said, subcutaneous air, all that pressure is building up, and find path of least resistance. And I've never seen sub-Q air, so. Hypertrophy of accessory muscle use. What would that tell you? Huh?
They're being used a lot.
Yeah, constantly. That used a lot constantly. So at the chest, is it a barrel chest? Is it a normal chest? Deformity, discoloration, asymmetry. What's asymmetry?
Not equal.
Not equal.
Okay. Flail segment with a paradoxical movement, adventitious breath sounds. A third heart sound. Third heart sound is usually indicative, with somebody symptomatic, usually we're looking for CHF. And you'll hear this. Or they'll say Kentucky, Kentucky, Kentucky. Fourth heart sound is Tennessee, Tennessee. Fremitus.
Another sound. What is it about the CHF that makes that sound?
Huh?
What is it about the CHF that makes that sound?
It's actually the mitral valve
Oh.
closing late.
Oh.
Because usually when you hear it, it's at, dun dun, dun dun. It's your aortic ventricular valves, and then it's your semilunar valves. And it's actually the fluid hitting against it that causes that sound, like a drum. How many firefighters in here? Have you guys ever heard the term water hammer?
Yeah.
If you turn on the water too fast, that water come in and will hit the pump and go bing. That's what that sound is. So, but yeah, your mitral valves, slowing, or it's a late. I don't know how I do it, but every lecture I always forget fremitus. Tactile fremitus. Anybody want to look that up?
Palpable vibration of the body, according to Wikipedia.
Oh. Yeah. Yeah. That's when you go tap, 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 tap.
Why?
Huh?
Why?
Hyperresonance.
So just whatever field you're listening to, just
Tap, 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 tap.
just hear it.
There's a bunch of
Echo.
different ones. Plural, vocal, subjective, tactile, passive.
Yeah.
The plural?
Huh?
When the plural are rubbing
Oh.
together.
Pleurisy. Pleurisy, but I was talking about how there's serous fluid. If you have whatever kind of infection, maybe you're losing serous fluid. You'll hear it almost sounds like two rubber balloons kind of grating on each other. That's what pleurisy is, and they'll usually say this hurts like hell, and they won't want to move because it's usually isolated to an area. So, anyway, focus exam extremities, edema. You guys know what edema is? Fluid accumulation, starts leaking out, all that business. Nail bed color.
I mean, you're confusing.
Oh, yeah.
Circulation.
Hmm?
That everyone's confusing it.
Well, what should it?
Blue.
Yeah, we don't want it to be blue. It's usually more accurate in children. We start doing cap refills in adults, but like I say, we want to make sure that it should be relatively pink. What's clubbing? Are you familiar with clubbing? Huh? Actually, it's the whole finger, the top of the actual digit.
Okay, so what's the deal with different things?
CO2 retention actually causes damage to the vasculature and gets a little big like that. It's not being able to cycle out. You get that from smoking too, by the way.
I have.
Hold your hands up. Let's see.
I'm double jointed.
No, I don't need. I don't need to see
I
if
was
you're.
like, don't look at my fingers.
No, I just want to see if you're got any clubbing yet.
No.
She won't let him still
Huh?
on.
You can come over here and look at him if you want to.
How about we take a break? Okay. Mechanical ventilation. Things about you got to worry about mechanical ventilation is, like I said here, we got increased resistance or changing compliance. The machine is just going to do what it's doing. You just set the machine to what parameters it's doing. How much tidal volume, how much respiratory rate, how much PEEP, this, that, and the other. But it doesn't sit there and always sit there saying accommodate for every physiological change that we do, especially if you have a deteriorating condition. You might have to change settings and all that other business. A lot of it, now we're not we're kind of just scratching the surface with vents. Give it a few more years, there's going to be a lot more probably vents added into the program, and because they're already adding in chest tube maintenance, and yeah, you're going to get that next semester. So, and Foley's, which I tried to fight, by the way.
We have to do that.
No maintenance.
Still,
Huh?
even maintenance.
I know. I tried. I
We're
tried.
with them 10 minutes.
Huh?
We're with them 10 minutes.
I mean, just not not a concerning or anything.
I think eventually it's going to get that way.
10 minutes. They can hold it.
I said, no, wrap them in more blankets. Let the nurse
Hey guys,
So what's going to be the point of a nurse then?
Yeah.
If everything's going to be done for them.
I've been asking that question for years.
What the purpose of a nurse is?
Yeah. It's one of those changing world things. Next semester we're going to be incorporating Foley's, and in fact, I was being asked today. He's like, "So what do you think we should have?" It's like, you're asking the wrong person. My answer is going to be don't. But new educational standards, Foley maintenance, or whatever the case may be, and
Ostomy.
It's coming.
Wipe it in.
I will be out of this job by that time that happens. I promise you. I will be long gone. No. Nope, ain't gonna happen. Huh?
No poop bags?
Nope. I've gone this long without, I've had patients go, yeah, I need you to take a look at my colostomy. No. I need to get new colostomy bags. No, I don't have any. Yeah. But now, we're going to be doing that. No. What was the other one I was trying to fight? Yeah, I know Foley's was one of them.
We're not going to put them on in clinicals, are we?
Huh?
Foley's?
No, I don't think
So
so.
it's just the mannequin?
I don't even know I think it's going to be more of a maintenance issue, not put them in.
Not as bad.
Just to say, putting on Foley's is not that hard. It's actually quite simple.
It's the culture.
Simple it is.
It's the culture. It's
disgusting.
we're just. I think the other one we were talking about for the a paramedic, community paramedic enemas.
No.
No. No.
I'll post on the street corner.
Yeah, I just can't wait till Chuck puts okays that one. I ought to give him a call. Hey, you want to have some fun with these guys? They're gonna have a class.
Give you the blue patch back.
They're having a class on how to give enemas to patients. That'd be a good disciplinary action when you think about it.
All your drugs you can do, that's all until you do it.
No, what's the point? Take the med syringe.
I know somebody who, I remember years ago, somebody actually got an ET tube, and why am I recording this, by the way? Pulseless paradoxus, you get me familiar with this term at all? Yes, no?
No.
Pulseless paradoxus, basically, you'll see this with a lot of your COPD patients. You get two systolic pressures, is what it is. You're taking their blood pressure, they take a deep breath, that increase the thoracic pressure they already have, pushes down on all the vasculature and on the heart, pressure goes down, and they'll actually write it two systolic numbers over the diastolic. So that's all it is. The other way you can also tell is you'll just sit there, hold their pulse, and tell them to take a few deep breaths and hold it, and you'll just feel that pulse get real weak and drop down, and they'll come back up as soon as you start breathing again. So that's really what it is. Like I said, and that's because, like I said, with the COPD, well, obviously with the tamponade, that's pretty self-explanatory because, like I said, we're putting pressure on the heart. With the COPD, we've got pressure all over in the thoracically because it's already at the lungs, usually hyperinflated at that point.
Like if you had a tension pneumo, could it create the narrowing pressure points like a tamponade would on the blood pressure?
It's not going to create a narrowing. The narrowing is because, like I said, it's a circumferential around the heart per se. This with the tension, you're actually getting your greater vessels, like you're including your superior and inferior vena cava. So that's why you don't have that narrowing.
Oh, okay.
Because you're hitting this, and that's going to, well, you do this, we're going to drop what's coming out on the other side.
Right.
Pressure goes down really quickly. Versus, I put pressure around the whole pump system, then I'm doing that circumferentially.
Okay.
I mean, you do get a circumferential with, a pneumo and stuff,
Right.
but you don't get the occlusion of the great vessels. History. Big thing with airway thing is, first of all, I can tell you this much, they always say, onset gradual, sudden, makes it worse, better, productive cough, et cetera, et cetera. Big thing I want to know is, are you speaking in full sentences? Are you having only 1 to 2 word sentences? Are you just nodding yes or no when you answer questions? Where are you? Where are you in my little, world on that curve? That's what I really want to know. And when in doubt, I can tell you this much, one of the best questions to ask is, are you getting tired to breathe? I've yet to have a patient lie on that one or try to play games on that one. But usually that you hear that, they're getting tired to breathe, you're pretty much get one of these ready to go. You're getting real close. They're going to give up on you, and you got to weigh that balance of, okay, do I let them go down and go unconscious, or do I snow them out while they still have an oxygen reserve and then put this in and keep the game going? So, but that's a big thing is just like a lot of this stuff, the onset, gradual. I mean, if they're relatively stable, we can kind of sit and ask, how long this has been happening, or what's going on, worse, better, how long, cough, productive, non-productive, pain. A lot of those bronchitis, pleurisy will give you pain. Obviously, fever. That's pretty indicative of infection at that point. So things you got to keep in hypertension, heart attack, diabetes. Why do you think hypertension? What could hypertension do with an airway issue?
More the pulmonary edema?
Yeah. Worst case scenario. Yeah. It'll turn into congestive heart failure because your heart's trying to kick against that pressure, and that heart will eventually give up. So the same thing, obviously, with an heart attack, is that you obviously, again, end result can be congestive heart failure because you've lost tissue, you've got a lower ejection fraction, and so forth. Diabetes. I really question. I guess they're trying to go, since they're going along the thing they're trying to go along here with more of the silent MIs. You get neuropathy with diabetes and stuff. Problem with is all that free floating sugar gets into the little microvasculature and ruptures it and kills, and then obviously those tissue starts dying off. That's how you also get a silent heart attack, because we're killing off all those pain receptors very quietly. So that's the thing. When you hear diabetes, it's always kind of like, well, where are you with your diabetes? Do you have any hard, because they may be sometimes, especially with MIs, they can actually be very atypical. So you just got to kind of keep a look for that. So, but anyway, chronic cough, smoking, recurrent colds. That's kind of self-explanatory. Allergies, seasonal, shortness of breath. Recent surgery, lower extremity trauma, mobilization. Again, we're looking at clots at that point, clots forming and breaking off. Overseas trips via airplane. You're sitting in a tube for 20 hours. That can do it too. Big thing, interventions. Big thing you want to ask. Well, one, were you ever intubated? They'll know. They'll know. And if they don't know if they're intubated, you don't worry about it. It's not a big concern, I guess. But the thing is, if they have been intubated or have been to the ICU, whatever their problem is, it gets bad. It gets really bad, especially like the asthmatics and COPD, other COPDers. They say, yeah, I had to get admitted a few times. Understand the situation can go very south very quickly. Medications, this is one of those, get familiar with the different medications, because, you're going to see a lot of albuterol out there, but then you're going to see like albuterol and Atrovent, then you're going to see like Combivent and all kinds of stuff out there. And you understand the bigger guns are coming as they kind of add going along here. And the thing is, how often are they using it? They so bad that they have to be, using albuterol every couple hours, on top of their steroids and everything else in the business. Are they taking inhaled versus oral steroids? If you're to the point where you're taking in oral steroids, we're looking to juice you up really good, really fast, kind of a thing. Past history, yeah, smokers. But yeah, if you've been intubated before, that's like that's a key indicator that, like I said, things can get really, really ugly. Okay, intervention, obviously, supplement oxygen, increased FiO2, increases oxygen availability. Again, we want to maximize oxygen saturation. And here's some dank sizes. I'll let you keep looking at it on your own. Understand irregulars make you from cylinder to cylinder, your high pressure, low pressure, cylinder to patient. Humidifiers, we really don't deal with humidifiers, but the thing is, the point of the humidifier is dry oxygen irritates the mucosa, irritates the cilia. Oh, I never finished what else smoking does, did I? Okay, so we have cilia, right? Okay, the cilia is actually based off a whole bunch of columnar cells that kind of stack on each other. And well, after you've been smoking for so long, you start losing those columnar cells. Okay, so you end up using your cilia and actually get replaced with what they call squamous cells. And these are very smooth, like, kind of like endothelial cells of your veins that really don't do any good for you. So when you smoke, all that junk just goes down and it stays there. So just one of those little FYIs for you.
Would you do it?
I'm here to help.
I can tell.
You don't need an intervention.
Huh?
You don't need no intervention.
Yeah, bring me along. I'm good at that. Nasal cannula. You guys are familiar with the nasal cannula, at 22 to 44%. Between 2 and 6 liters a minute. Again, we're trying to keep. I was thinking of the cannula. We're trying to keep oxygen. We're not too worried about it, but we just want to keep it a little bit up. Something you might say we want to keep it just in the middle, mid 90s or something, but it's not life-threatening per se at this point in time. Obviously, if they're apneic, we're not going to be giving that. I hope not. So obviously, if they need more, we're not going to give a cannula at 10. Gust of air going up. Huh?
Blow their eyeballs out.
Yeah.
Yeah, right.
So Venturi mask. You don't see much of those.
Mostly on trach patients.
Yeah. So you can just set, and that's all it is. You just set specific concentrations. Simple face mask. Once in a while, you see those pop up, 60 to 40, 10 liters per minute. Just kind of, again, moderate. Again, right tool, right job. We need just something a little bit moderate. Give them a simple face mask. Non-rebreather, we pretty much deal with a lot. 80 to 95%. Obviously, poor respiratory effort, apnea, we're going to scratch that. Partial non-rebreather. BLS maneuvers, obviously head tilt, chin lift, head tilt, whatever. Head tilt, chin lift, jaw thrust. They're traumatic. Celix maneuver. We're going to include the esophagus. Other things you got to worry about, tracheotomy with the tube and tracheostomy with a stoma. Tube is easy. We can attach a BVM to it. Everything works. We're fine. The stoma, we just got to put the mask over it and ventilate that way. And the problem is just keep their mouth closed because air is going to go past least resistance, and it's going in two directions at that point. So oral pharyngeals, nasopharyngeals, you guys are familiar with that, I assume. So other BLS methods, mouth to mouth, mouth to nose, mouth to mask. So do I need to really go over BLS with you guys? All right. One person BVM, they say it's difficult to master. You'll be expected to be very, very proficient at this, especially when you go to the OR. They want to see that you're good at this before they start letting you play with tubes. So
The OR or the ER?
both. Both are going to want to know. The only thing you have to worry about is just, again, seal is very difficult. You got to really play with the technique to really kind of grip that face and grip that jaw. And like I said, you got to worry about gastric distension at that point. But again, the big thing you're going to see here with a lot of this ventilation, ventilate till you only see the chest rise, and that's it. Once we get enough oxygen, those lungs have already inflated. Now we're just inflating them enough. Open actually movement in the chest. Two-person, usually the more effective. Useful in a C-spine injury. Have you guys ever seen two people VVM? I had a paramedics do that once years ago. On a cardiac arrest, fell over laughing. I'm sorry, but it was funny. We're going to get ready to do the cardiac arrest. I start ventilating. My partner's doing the other stuff. She just comes up, puts her, okay, you got seal! He just yells us right in the house. I'm like, I'm okay. Can you start compressions? What? Yeah, I'm okay. Kind of thing. It was kind of funny. We got seal! I'm like this far away. Three-person, I've never seen three-person. I've never seen a three-person.
Who's the third person do?
I don't know.
Moral support? I mean.
That's good. You're doing a good job there. Yeah.
Probably.
Makes the seal one holds
Crowded, I would think it would be crowded.
that, and the one that squeezes the bag.
Yeah, flow-restricted gas-powered ventilators. You guys know where the cardiac sphincter is, by the way?
Isn't that the one that's on the stomach?
Yeah. That's right in between your stomach and your esophagus. So, it's not recommended for children. Can blow their lungs up. May cause barotrauma. You know where that comes from? Where this device comes from? Firemen. These guys will run into fires and have to go into rehab. Juice themselves up with oxygen.
Is this supposed to say oxygen-powered ventilator or gas-powered?
It can be either or. It's oxygen is a gas. So, automatic transport ventilators. Yeah.
I was thinking crank it up. And
Okay. This is you'll see a picture of this in your book, and this is actually this is actually a gas powered too. It relies on the pressure of the oxygen. It only controls volume and rate, so how much air is going in and what the rate is. So again, it's not useful for prolonged times because, like I said, it's relying on pressure of the actual oxygen tank to do this. So obviously not useful in increased airway resistance. Like I said, it's not like a ventilator. Some of those ventilators will try and sense the air, how much pressure it's against, and they'll back off of it, saying, well, this is too much pressure, back off. This isn't going to do this. A lot of times, it's, like I said, this is kind of like a real quick transfer kind of a deal. So, relatively new out there. This is a relatively new one. So, pediatric considerations, mask seal may obstruct airway. So just be careful when someone yells seal. I have seal on a pediatric patient. BVM sizes, you got your neonates, 15 mLs. Children over 8 require an adult, obviously. Squeeze, release. The big thing to always worry about is overinflating a child's chest. Okay? If you're really that concerned, ventilate, see the chest rise, lift off. Lift the mask off, let it go back down. Some people get real nervous and they'll put their hand just to have that weighted pressure. People freak out in kids. I can take this much, just relax. If you're that concerned, just let it go back down. Puff, puff, so forth. Again, stoma. Actually, a nice thing if you have a stoma that we can do is These are great for stoma problems. But if you don't have that, like I said, it's obviously we try to use a pocket mask BVM, but just understand air is going to come up out this way. So you got that problem there. Obstruction techniques. Obviously, you know the sweep, finger sweep. You know, probably, you know, just don't choke around me because you know my chances are of me sticking my fingers in your mouth. Yeah. So just other than that, suctioning. You guys, you know, remember how to suction? Go down as far as you can see. Suction on the way out. Why?
Because you're sucking oxygen out.
What else?
Listen to tissue berries.
If I have a bunch of fluid in there, and you shove that thing in there, what could happen? Okay, there's fluid. I have a big chunk of meat sitting under there. I shove that thing down. That's why I say go as far as you can see, then back out. Because you might have to get that fluid down lower and say, oh, wait a minute, I got to pick this up and out. Other than that, you might shove something in there, that trachea, and cause a bigger problem. So obviously you know your oral nasal airways, Heimlich maneuver, chest thrust, back thrust, inflows, blah, blah, blah. Oh, we'll talk about direct laryngoscopy. Again, nice thing about it, lift up, suction, suction, pull back, play, you know, get your McGills. You got a better view. So that's an option too. Things if you need, think about this, you know, think about with suctioning, I mean, obviously you got to get rid of the obstruction. So do what you got to do. Get rid of whatever's in the way, fluid, you know, vomit, blood, teeth. You got to get that in the way. And if there's too much fluid, this is where you're going to need this the most, because this will come in and at least, you know, blow up and protect against some fluid coming down. Now kind of secure your airway. So I think we're going to do differently here. I mean, I'm sure you guys are familiar with the rigid catheters. We're going to go into soft catheters. Think about soft catheter. You just measure from, you know, what they call, you know, angle of Louis to the tip of your nose. And we're just going to insert this down the tube and do the same thing. We're going to suction on the way out. The reason why we measure it is we do not want this migrating past and going down to one of the tissues and damaging anything.
So what's the benefit of the soft catheters?
It suctions the tube. Soft suction is for suctioning because you're going to get people with like pneumonia or CHF or something, and it's going to get in the tube. So you just go down there, pull it back out. You know, clean off some water, go down there, pull it back out. It's a good time. So gastric distension, common with ventilating without intubation. Obviously, we talked about. Obviously, pressure in the belly, diaphragm, so forth. Like I said, the ways around it is one, we try to get an advanced airway in there, or we get an OG tube or an NG tube, and we can start sucking stuff out. But you can tell gastric distension, your belly will feel like a little balloon sitting right here, or their belly will. Well, that was it.